बताइए, नागा को कभी कहीं जाना रहता है तो कैमरा ऑफ करके निकल लेती है अपना बिना पूछे हुए।
Sorry, doctor, we are live, please.
Yeah,
Okay.
right.
Shall I start, Mr. Sunil?
Yes, ma'am, we are live.
A very good evening to one and all of you for one more very interesting ARC webinar, video bouquet of cataract challenges. And I'm sure by now you know that you would be exposed to a wide variety of challenging videos, which the expert panel would ensure that you have learned it all absolutely the right way. We are truly lucky to have with us on the panel the best of expert panel to ensure that the next 2.5 hours is going to be packed with learning. We have with us Dr. Rohit Om Prakash, who heads the Dr. Om Prakash Eye Institute from Amritsar, a veteran, a prolific, a dynamic surgeon he is, and he has actually initiated amazing educational programs on coming at an annual basis and has kept us all waiting for his program and learning to come from that. We have with us Dr. Arulmuri Varman, another pioneer of phacoemulsification, he heads the Uma Eye Clinic at Chennai, and he's probably one of the highest numbers of multifocal IOLs being implanted and the most complex of surgeries. And you can imagine what a boon he is going to be for this meeting. Joining us soon is going to be Dr. Arup Chakravarti, who's the chairman and medical director of the Chakravarti Eye Care Center based at Trivandrum. And as we all know, he's one of the most efficient of editor proceedings we've known, and he's brought so much of learning on that platform. We have with us, smiling at us, Dr. Kamal Kapoor, who is the founder and medical director of Sharp Eye Center. It is now multiple centers, each outbeating the other. And with his astute intelligence and skills, he is probably way up on the calendar as one of the very prominent, successful entrepreneurs of our country. Moderating with me is Dr. Anaga Harur, who is the medical director of Anil Eye Hospital, who's also the member ARC West, and again, quite a prolific surgeon. We have with us co-moderating Dr. Satyajit Sinha, who is the chairman and medical director of ABI Institute based at Patna. He's a cataract and glaucoma and refractive specialist, and he is member ARC East for the second term. And believe me, he is a friend to all and is quite a national figure to be reckoned with. And I'm truly glad to have two strong moderators with me to run the show. Dr. Vaishali Lalit has apparently not yet joined. And I think we would go on to Pratik, Dr. Pratik Nishant. I mean, we have to change the sequence a little because the first two would join soon. And Dr. Pratik Nishant is a young, dynamic senior resident from AIOS Patna, and he has a different thought process for us to dwell on. On to you. You can start sharing your screen.
Thank you so much, ma'am, and good evening to all. Let me share my screen. I hope it's visible now.
Yeah.
The video is visible, ma'am?
Yeah.
Okay.
The title of this video is Man Proposes, God Disposes.
We don't see your screen. Why am I coming on that screen?
The title of this video is Man Proposes, God Disposes. Last case of the day, cooperative patient under topical. Here's how it looks after cortex aspiration. What could possibly go wrong? But then God says,
मजा नहीं आ रहा है.
a hydrophilic acrylic foldable IOL is being loaded into the cartridge. This is the only lens in the inventory suitable for the patient. The surgeon is very meticulous to place it well, but then the cartridge doesn't close as the lens pops out.
बच गया साला.
Any further pressure on the cartridge could have damaged the lens. The surgeon repositions the lens and this time, the cartridge closes nicely. This is the 2.8 mm injector system supplied with the lens. It is known to misbehave sometimes. As the lens is introduced into the eye, the leading haptic appears to the right instead of the left. The surgeon twists his wrist to orient it correctly. This was, in fact, a mirage because now the whole aisle gets uncontrollably injected upside down.
Music.
Viscoelastic is injected in front and behind the aisle and there is only one thing left to do now. The surgeon uses two Sinski hooks, one through the side port applied to the top, and the other through the main port applied to the bottom of the flipping optic, losing control briefly but again regaining and successfully flipping the aisle. The aisle is gently dialed into the capsular bag under viscoelastic and the surgeon breathes a sigh of relief. But as they say, it's not really over until it's over.
रुको जरा, सबर करो, बोला धक्का बुक्की नहीं करने का, आराम से लेने का, हाँ.
Irrigation handpiece in the left hand, aspiration in the right. Watch what happens with the latter.
खत्म. Bye bye, Tata, goodbye, गया.
Losing the anterior chamber briefly but then switching to foot pedal 1, the aspiration tip is manually withdrawn from the eye as it got detached from the handpiece. The aspiration handpiece is changed and viscoelastic removal completed. The patient had a beautiful outcome on postoperative day 1 and regained corrected distance visual acuity of 6/6 at 1 week follow-up.
Thank you, Dr. Pratik. So I have just a thought process. I mean, I would want my expert panel. I'm sure they agree with me. Had he not used the main port to revert the IOL and gone through the left side port, you know, his anterior chamber would have been shallow. He could have ended up with a PCR for all we know. So the main port should actually be used only for inserting the phaco probe and in and out. And I also noticed there was a crack on the side, on the left side, linear crack was there on the optic of the IOL. Now, what could be the cause of these cracks, Dr. Kamal? What could you think? Why could it also have flipped? What could be the reasons for that? Have you ever questioned these things have happened in our hands too?
Yeah. As you see, Dr. Chitra, I think it was a good, very honest video which he demonstrated, and it's very honest video to show. Yeah. And most of us can have IOLs which do flip around. Few reasons of IOL flipping around are the cartridge size sometimes is mismatched. You know, there are a lot of cartridges which are still available at 2.8. and you're using a low diopter lens. Let's say you're using a +15 or a +12. So the lens being thin and large internal diameter of the cartridge, as the lens goes around, it may be tending to rotate. That's one. That's the first problem is this. Number two problem could be while loading the lens, there is a more bias towards one side in the tunnel of cut. So as the lens moves, the bias increases and it tends to rotate. Sometimes we are so keen while injecting the lens, we don't notice the rotation of our wrist. And as the lens is going in, we might rotate our wrist maybe 10 degrees, 20 degrees. And as the lens comes out, it rotates. And the fourth reason to my mind could also be, there could be a sudden jerk at the last part of the travel journey of the lens. At that, it could be rotating. Fifth point, hypertonic anterior chamber. So there's less amount of viscoelastic, which is giving resistance to the IOL to open. So all these things can lead up to the problem. But I did notice that, the point you mentioned of not doing these main maneuvers of resetting the IOL from the main wound once the catastrophe has happened would help. And you could probably land up with a PCR actually. And the lens sometimes can be standing vertical in some situations and cause a Descemet's issue and also the posterior capsule issue.
Yes. So do you think then the pre-loaded system, Dr. Rohit Om Prakash, are actually proof to any of these problems happening? Do you feel it that way? Or is there a challenge there with the preloaded lenses?
I think the challenges are quite less as compared to, when we try to, or our assistants load it. But all said and done, if it happens, because it does happen with everybody, I think you really put forth the true pearl, and that is not using the main port, because you need to have stable chamber settings. Two ports have to be used and it has to be flipped. That is the key to it, and it happens with everybody. Yeah. So sooner or later, if it has not happened with somebody, it will really happen. So we have to be ready with all the pearls, as you have already told.
Yeah, agree. Anaka, do you have anything to ask, or should we?
Yeah, madam. One more point is sometimes in these hydrophilic lenses, there is this silicone blue plunger. So one of the haptics, that is the trailing haptic, can sometimes get engaged or entangled in that. So I've also experienced sometimes that when you're pushing in the entire lens, that haptic
overriding
gets
can happen. It can get overriding also can happen of the plunger.
Yes. So that also can cause, and then I think maybe we just need to keep your eye on the opening of the lens. If you feel that it is not opening in the right direction or tending to flip, we need to wait, be more gentle, and then inject it very, very gently. If you are a little jerky, then sometimes that, like sir said,
he very nicely twisted his hand. Very sensibly he did it so that it actually was opening up, but then it flipped again. But that was a wonderful thing which you showed, Dr. Pratik, and for such a young guy as you, that was a very brave move as Dr.
I have one question here. Can I ask?
Yes.
Ma'am, is it necessary, like in aspheric IOS, to rotate the IOL? Will it make any optical difference? Because in aspheric IOLs, I don't think rotation or putting the lens in wrong orientation makes any difference.
In the sense, it should not be upside down. We need to understand with asphericity is on the front.
Yeah, the leading haptic towards left kind of orientation, the anti-S kind of orientation.
So that is the angle. If it is angulated anteriorly, those lenses, it can be a problem. Like for example, if you have a lens which has an anterior angulation and you are putting it upside down, then the angulation will be in front.
No, he's not talking about upside down, which I was thinking. What he's trying to
I am asking about an optical property. In the optical properties, will it make any difference?
Yes, Dr. Arun.
This is the question I had in mind.
Yes.
What if we left the lens upside down? Nothing is wrong. We'll have to understand the optics here. If it is a very, very high power lens, something like 27, 28 or very high power lens, putting it upside down, you can land up with a small refractive error. Number two, when you're dealing with aspheric lenses, if you put it upside down, you lose asphericity.
Yeah, that's what.
If it is a spherical lens, you lose nothing. The third point is that as long as the lens is not having any kind of an angulation, the only single piece lens that is sold in India having an angulation comes from J&J. You don't have to worry about the issues at all. you can actually leave it back this way. But of course, one needs to learn how to handle these situations. It was handled very well. As Kamal Kapoor said, the most important point here, the mistake here would have been a small error in the loading and a slightly hypertonic anterior chamber, both together led to the lens flipping.
Yeah.
Yeah.
Very rightly said. I think we shall go on to our next speaker. Would Dr. Soni Sinha take it on, Dr. Pratik?
Ma'am, I would like to congratulate Dr. Pratik. He is also from Patna, and I must tell you, every quiz, every competition, he wins the first gold medal, first prize everywhere in all the competitions. Congratulations, Pratik, for the wonderful presentation.
Thank you so much.
Pratik, I should also take credit for discovering you for ARC first.
Thank you, ma'am. Thank you. Actually, the virtual background is not allowing me to come onto the frame. But actually, when Chitra ma'am asked me to be part of the ARC program on cataract surgeries, difficult cataract surgeries, I said I'm at a stage where I create more complications than I actually solve them. So this was one video where I actually solved my complication. Thank you, ma'am.
Thank you. So we have our next speaker, Dr. Soni Sinha, who is a senior ophthalmologist from the Department of Ophthalmology of Patna Medical College. And she is going to show us a different situation, a traumatic cataract. On to you, Dr. Soni.
She is Dr. Pratik's mom.
Yes, Dr. Pratik.
Thank you so much, and thank you for your kind words for Pratik. Good evening, everybody. It's a real pleasure and a privilege to be a part of Chitra ma'am's team.
This is a case of traumatic cataract being managed by a resident surgeon. Side ports and main port are constructed, and the anterior capsule is stained using trypan blue dye. Dye washout is followed by viscoelastic injection, and capsular excess is started using a 26-gauge needle cystitome and completed by utrata forceps. Size of the capsular excess is kept around 5 mm. Should the patient require a posterior chamber intraocular lens implantation, the ciliary sulcus. The anterior chamber is filled with viscoelastic, and irrigation and aspiration introduced with low parameters to avoid excessive push on the lens matter. However, posteriorly directed irrigation fluid jet leads to widening of a pre-existing posterior capsular tear and instant prolapse of residual lens matter into the vitreous. Aspiration is stopped and the probe withdrawn. Dispersive viscoelastic is injected into the anterior chamber before withdrawing the irrigation tip. Time for anterior vitrectomy. Meticulous anterior vitrectomy is performed to clear the anterior chamber of all vitreous. Some lens matter from the vitreous does come into the vitrectomy cutter, but fishing for the prolapsed fragments is avoided. Care is taken to avoid extending the posterior capsule tear by the vitrectomy cutter. Care is also taken to avoid iris trauma. Once the lens plane is clear of all vitreous, the residual cortex can be aspirated using the vitrector or the aspiration handpiece. A 3-piece IOL, or a rigid PMMA IOL, can be implanted in the sulcus. To allow access for the rigid IOL, the main incision is extended using the keratome. An IOL with a 5.5 mm optic has been selected for implantation in the sulcus. This IOL is introduced using McPherson's forceps. Intracameral pilocarpine is injected to constrict the pupil and a large air bubble forms the anterior chamber and confirms absence of vitreous. A single 10-0 nylon suture in the middle of the main port, along with hydration of the walls, is sufficient to close the incision. Intracameral moxifloxacin is injected, side ports are hydrated and the case is closed.
Thanks a lot, Dr. Soni, for bringing up some more thoughts for discussion and something different from the routine. As far as new vitrectomy is to be done, I somehow feel I would always suture the main wound and go in through the two side ports and keep the infusion cannula away from the vitreous so that it doesn't overhydrate the vitreous. And through the other side port, I would do the cutting. The other thing is, sometimes you may feel inclined to enlarge the corneal incision, but in this particular situation, you know, it does make sense to create a scleral tunnel, which seem to be probably augurs for a greater stability of the wound. Like, these are my two thoughts. I'm sure we could, my expert panel would add to their own. But in a case of a traumatic cataract, would we, all of us, understand that we should do a B scan, and if possible, we have access to ASOCT, we should do that. Dr. Arul Muivarman, are you there?
Very much. I'm here.
Yeah. So then, if you were to suspect a PC tear in a traumatic cataract by getting information from ASOCT, what would you have done? I'm sure you wouldn't have gone in with a bimanual IA at that point. Would you have?
Okay. First thing is maybe not then the OCT, we would have probably got information from the B scan also.
Yeah.
So this would have forewarned me to keep the VR surgeon standing by.
Yes.
So that once we have started and we see that the posterior capsule is split, stop everything, and then the VR surgeon would take over, do the vitrectomy, and then of course rest of it is very, very similar. Nothing lost in this case also, just that it was soft material, so it's not going to be very difficult for the VR surgeon to do. So whatever has been done is that the second surgery has been deferred to another day. That's about all. You've not lost anything here. But it would have been probably the very scientific way would have been to do a B scan.
Yes.
An ASOCT also sometimes can miss it in case of very dense cataract. It may not catch the posterior capsular rupture, but such a rupture may have been caught by the B scan. We probably should do one for all these traumatic cases.
Dr. Rohit, would you do anything different when you start the case? We tell her that you could have done a B scan and ASOCT. You believe that the posterior capsule is open. Would there be anything else which you might have done?
Yeah, I think you have to see the anterior chamber depth also, because in these patients at times, you know, the anterior chamber depth, despite the increased lens thickness, may be more. So that at times gives us some indication that there may be a rupture. That's the first thing. The second thing is that I would definitely go in for a low IOP one, wherein the fluidics have to be, you know, on the more pressure in the anterior chamber, which should push things behind. That is the second thing which I would have done differently. The third thing which I would have done, I would have created a smaller rhexis, because in case I wanted to do an optic capture, I would be able to do it at a later stage.
Yes.
So otherwise, if you ask me, she has done it perfectly well. And since there was no 3-piece intraocular lens available, so that was implanted. That is fully justified, because we also at times when we do not have a 3-piece in our inventory, we do put you know, a single piece intraocular lens. But then, you know, you realize that you have to be really ready for it. When you have a low pressure situation, when the bottle height is less, you know, we are creating a situation wherein, you know, with the fluidics, the lens material is not being pushed behind. It, as a matter of fact, is floating. So the chances of, you know, the lens matter getting, you know, pushed behind, that also gets. and also the hydration of the vitreous also gets decreased. So otherwise, I think it was perfectly done, and I would like to congratulate her for the ultimate outcome.
The other question, Dr. Kamal, would you at any point of thing, this it's very little fluffy cortex only which is gone into the vitreous. Would you think, shall I observe or should I do? I agree. The first thing, as Arun said, a traumatic cataract, when you're not sure of the posterior capsule, always surgery in the retina theater itself, because some of these younger children, they could be under GA and it becomes difficult to shift them from one theater to the other, unless you're in a multi-speciality hospital. So what I want to know is, what do you have a percentage of cortical matter which should go into the vitreous, because this has to be a second sitting in this particular scenario. So what would you feel?
Okay, before I start with the answer, I think I definitely agree with what Rohit said. I would just say that the only addition I would have to what Rohit said was, I would prefer a slightly, and I'm suspecting that I would be needing an optic capture or even a 3-piece lens, because in my hands, I think this really adds a huge advantage to my IOL placement. Having said that, a slight amount of cortical matter getting into the vitreous, and especially when you don't have a retina surgeon standby in your organization, I don't think it's a bad idea to put in the lens, do the anterior vitrectomy, and try and fish out the remaining part of the vitreous, because then you're probably causing more harm than you're causing a benefit to the patient. Observing these patients for some inflammatory changes, vitritis or glaucoma. In case in these situations you don't see any, it's not a bad idea to put these patients on some sort of systemic steroids also. That's what I do in my practice. Observe them for a little while, and if nothing goes wrong, I think you can wait for it to blow over. But in case you feel there are signs of inflammation, so glaucoma, IOP rising, vitritis, or some kind of reaction, that is the time probably I think you should probably refer it, in case you don't have a standby retina surgeon in your team, to another such retina surgeon to take over. But if it's a very small of cortex, let's say a fluffy cortex, I don't know how to quantify it, but it's a gut feel. It tells you that this is a very small amount of cortex, and you can probably wait and watch and see how it behaves. It's not a bad idea, especially in a situation where you don't have vitreoretinal surgeons in your team, and you wait and watch and observe the patient and refer if required at a later date.
Yes, right. I think we all said it all. So thank you very much, Dr. Soni. Do stay on with us, and we would look forward to any thought processes of yours over the ensuing videos. Thanks a lot. The mother and son make a great team. We go on.
Thank you, ma'am. Thanks for the inputs. Certainly, we have got some constraints of not having a vitreoretinal surgeon in the first place, and not having a 3-piece PMMA available or 3-piece.
That is all absolutely right. But then we wanted to use these webinars to discuss everything piecemeal, so that we all go back to the right information. We go on to our next speaker, Dr. Shubhangi Nigwekar, who is a senior consultant ophthalmologist from the Medical College at Ahmednagar, Maharashtra. And she has a little different situations to show to us. On to you, Dr. Shubhangi.
Thank you. Good evening, all. And thanks, Chitra ma'am, to consider my name in your team. And I'm so happy. I'm sharing this video.
Oh, it's your birthday today, Dr. Shubhangi.
Yes, ma'am.
Happy birthday.
Happy birthday to you. We robbed some of your precious birthday times by forcing us into our webinar.
Happy birthday to you. Thank you so much. Thank you so much.
Happy birthday. Happy birthday.
Thank you, sir. Thank you.
Thanks, Harshul, for telling us.
Happy birthday.
Mr. Sunil, I think you're supposed to share her video.
She was sharing. You want me to share? I'll share.
Yes, you could share it, no?
I hope I should start.
Yes.
Hello viewers from Dr. Shubhangi Nigvekar. In this video of manual small incision cataract surgery, let us see two cases.
Ma'am, is it visible?
Yeah.
All clear, doctor. Please go on.
Okay.
One has the eccentric corneal graft and other has the central corneal graft. This patient had advanced cataract in left eye. See the temporally placed eccentric clear corneal graft and see more host cornea superior-nasally. So I have constructed larger scleral and shorter corneal tunnel to prevent any touch to the graft host junction. Central superior AC entry, no staining, and under visco protection CCC was carried out and capsular button was removed. Then the gentle hydrodissection was done. Nucleus delivered in the anterior chamber with the help of dialer under visco protection.
You want to go next?
Due to the large and hard nucleus, side cuts taken in tunnel.
No.
And nucleus delivered with the help of vectis. Then with Simcoe cannula, thorough cortical wash and aspiration was done. Visco was injected in the anterior chamber. Then the rigid PMMA IOL was implanted with bimanual technique. First the inferior haptic, then the optic, and then the superior haptic. IOL dialed and haptics kept horizontally. After visco wash, air was injected in the anterior chamber and two sutures taken, one temporally and one nasally, and thus reformed the tunnel integrity. Then the conjunctival reposition and subconjunctival injection was given, and this is happy patient post-operatively with 6/18 vision unaided. Now this is a second case which has a central corneal graft and grade 3 cataract in the left eye. Same rule followed, larger scleral and shorter corneal tunnel to protect the graft host junction, AC entry made superiorly, capsule stained with Blurex and wash given. Visco injected and CCC done with cystitome, and then capsular button was removed with Macpherson. Tunnel extended with keratome and funnel was constructed. Gently. Then the gentle hydrodissection was carried out and the rotation of nucleus in the anterior chamber with dialer was done. Under the visco protection, nucleus delivered out with vectis. Thorough cortical wash was done with Simcoe cannula with visco protection. Rigid PMMA IOL was implanted with bimanual technique and dialed properly. Visco wash was given. AC formed with anterior with air, and the conjunctival reposition, speculum removal, subconjunctival injection given, and the patient had 6/12 unaided vision on first POD. Thanks for watching.
Thanks a lot, Dr. Shubhangi, for your two wonderful videos. Looking at it from the cornea perspective, does it make sense to document an endothelial status for whenever we take up these cases for cataract surgery?
Yes, ma'am. It is absolutely right that we are supposed to go for endothelial counts, and then only we are supposed to. But unfortunately, our institute is not having SPEC micro. That is the only thing, and we are doing many keratoplasties with the aids of moist chamber. technique only. So preservation. So
you had made those relaxing cuts. Your incision was quite large.
Actually, that was my first case, ma'am, small incision cataract surgery. And that lady was a one-eyed patient, actually bilateral blindness, and some vision was there, immature cataract. And after successful PKP, she had some vision, and then she again became just blind because of the mature cataract. Then my fingers crossed, so I was very much on the stove actually. So I respected that endothelium, and I extended and reformed and awarded that some small incision tunnel integrity by taking the sutures.
Yes,
And
yes,
ma'am.
Yeah, no, very wonderfully done. The other question, Dr. Rohit, like if we are challenged in getting a K value in these corneas are a little hazy to start with, what would we do, you think? Probably. Or would Shivani want to tell that, again being a cornea person?
Yeah, I'm not a cornea person, but definitely whatever we can with the normal on the IOL master, which we usually do. Take that and we go ahead with that, and telling the patient, that there can be some surprises, number one. And in these patients, you have to tell the patient that there's a chance of graft getting opaque. I have no experience of doing SICS in any case whatsoever. So my preferred choice would be doing phacoemulsification in these patients by using, viscoat for endothelial protection. So that is what I would be doing. And I would be making, as she did, by creating a scleral incision also with the partial corneal one. So that, since the graft was slightly eccentric in one of the cases.
Yes.
So that is what I would be doing.
True. Dr. Kamal, you want to add anything?
Yeah. I think I agree with Rohit again, coincidentally. I would probably go for a, outer limbal incision or probably partially scleral. I'd divide the conjunctiva slightly, retracted, because I want to be as away, because the major amount of manipulation which is happening in the anterior chamber is just next 1 millimeter to your instrument. So if you're peripheral, your chances of hitting the endothelium and causing more problems is reduced. Number two, what I would do is probably I would reduce the bottle height by 10 centimeter or so, because if my bottle height is high, probably I'm causing more endothelial stress to the, this is apart from using any product like Viscoat. Number three, I would probably have a slightly larger side port, because I've operated such patients, and as Dr. Rohit said, even I don't do SICS and I've done phaco in such situations. I make a slightly larger side port, a wee bit larger, to have a decent amount of leakage which is happening. So at any point, without having a surge or an AC collapse, I have a continuous flow of fluid, and I don't have an increased IOP, especially when there is an occlusion of my phacotip, because that's the time the IOP goes up, because your pressure water is coming in, the tip is occluded, there's no outflow. And even while doing your irrigation aspiration, when your port is at, just for those fraction of seconds, your port is occluded and the fluid is coming in, because the fluid input at the time of irrigation aspiration is something like 78 to 82 cc per minute, and the IOPs can go very high at that time. So in my personal opinion, I feel that could cause some endothelial damage. So I make a slightly leaky side port, which means I can be in the plane of the side port when I want, but the moment I feel my AC is deepening, I slightly dip the scleral lip and make the side port leak slightly and maintain the anterior chamber maintained. And I have had very good results with using this technique in most of my patients. And I think that this works in my hands.
Dr. Arun Varman, do you have anything to add, or we move on?
No, it's been done very well, handled beautifully. End of the day, the patient should get the benefit. As the other two speakers have already mentioned, we have very little experience with manual small incision. Yes. We would have still gone ahead with phaco with appropriate modification in our technology and probably got away with it. But this has been done beautifully and well done surgery. So at the end of the day, we'll have to see as to what you're comfortable with and make sure that you do not damage the endothelium in these patients. They're very, very precious. Take all steps possible and do the procedure.
Yeah. We're going to change the sequence a little because Dr. Dipti Joshi has some other commitment. We have with us a very dynamic young lady, Dr. Dipti, who is the senior consultant pediatric ophthalmology and squint specialist from the very famous Joshi Eye Institute based at Hubli. It needed to go there to understand the kind of volume of work which they do so amazingly well. And truly kudos to all the leaders of this hospital. And she's going to be showing us another interesting case, how easily she managed it. On to you, Dr. Dipti.
Thank you, Chitra ma'am, for this opportunity, and good evening to all expert panel. So, I think just a minute. I had to share some. This is my video. Hello everyone, presenting a case of traumatic cataract management with iridodialysis repair. A 15-year-old boy presented to us post-corneoscleral tear repair for the management of his superior iridodialysis and traumatic cataract. After adequate capsule staining, the iridodialysis repair was taken up as the first step. Unfurling of the iris, release of synechiae above and below, and protection of the iris with adequate viscoelastic was the first step. This was followed by a scleral flap in the zone of iridodialysis. We then passed a proline single-armed needle through the scleral flap, fed through iris as close as possible to the root of iris, and that was externalized through another port. Same way, we passed a bent 26 gauge needle through iris and fed it with the externalized proline needle and the suture. So this way, a loop is formed at the detached iris, and tying the suture ends now opposes the iridodialysis. This technique is based on McConnell's. Then, through a clear corneal incision, cataract management was initiated. Rhexis and adequate hydrodissection was done, and the soft nucleus was aspirated out. After adequate cortex removal, a multi-piece IOL was placed in the bag. This was followed by suturing of both the scleral tunnel as well as the conjunctiva. This is the post-operative bit. So finally, all's well that ends well. Thank you.
Yes, wonderfully done surgery and very well done, Dr. Dipti. Just that you must have done probably an ASOCT and taken a call. I would treat all these traumatic cataracts as if they are polar cataracts. You know, I would be very, very cautious about not doing a hydro in these cases because we never know. Already there was iridodialysis repair too. It is just my thought. I would want my expert panel to think on that. But since you are a pediatric surgeon, very relevant to your specialty. Now, this was a 15-year-old. So you would have just done the regular biometry and placed an implant. Now, supposing this was, in fact, say a 5-year-old, how would you plan your IOL formula for this?
I might actually go with the formula of less than 2 years of age of 20% undercorrection and more than 2 years 10%. But I don't fully undercorrect them. Now I have, as of late, I have started following a 50% undercorrection of what I used to follow before, because somewhere I used to feel that if it was 25 and I used to undercorrect them by plus 2.5 or plus 3 by 20% if it goes to 5, I used to leave behind the child with plus 5 diopter of hypermetropia. A child which was not seeing anything suddenly used to feel that whatever he is seeing is actually good for him, and that plus 5 diopter of glasses used to become intermittent from the parent's point of view. So aiming that the child becomes emmetropic later, somewhere I was making the child amblyopic now because of his intermittent glass usage. So now I think our refractive surgical department has come up to a great extent that is maybe an -4 to -5 myopia they can manage very well later. So I undercorrect them by 50% of what I used to do before. So less than 2 years, now I do 10% and more than 5%. Less hypermetropia to begin with, at least the amblyopia chances are less. Maybe a moderate amount of myopia later, but that can be managed well at that age group is what I believe. I think experts would give their input also.
It's a very valid thought process, because it becomes a challenge when they are left hyperopic. But I think many places they practice this rule of 7 minus age, and that becomes the IOL power which is implanted in these eyes. But you know, sometimes you could have a very significant myopia too. But I suppose with your volume of work, you would have found this a practical solution. Does anybody in our expert panel have any other thing to add to what she's saying? Because I think these are very valid thoughts which are there. Anything else to comment on about her surgery?
About the surgery, nothing to comment. It was a fabulously done surgery. As to what kind of an IOL and how much undercorrection you put in, or a DP was very clear. I think I agree with whatever she says. We need to bring these children as close to emmetropia as possible.
Yes.
Not keep them too much of an emmetropia so that goes into amblyopia. The fact now is, how many of us are going to be comfortable putting in a multifocal lens in these patients? Are the 15-year-old or even a 10-year-old? Let's put this question. A 15-year-old eye is not going to grow very much longer. Would you be interested in doing that?
Yes.
No.
Why? Okay.
Why?
Why? Yes, your thoughts, Dr. Kamal?
Okay, first of all, I think excellent surgery, perfect. But what I normally do in such situations is, when I'm trying to actually repair an iris, is I, rather than making a flap or a square shaped flap, I make a ridge, which is just like the way you dig a road for putting in a pipe. I make with my MVR blade, I just make a little ridge, which is half thickness of the sclera. I use that. I used to do your 26 gauge needle initially, but I've realized over time that's 26 gauge needle, once it goes through the iris, makes a bigger hole and causes atrophy there. So with a lot of practice, I've kind of can come through that ridge. So I don't need to suture that flap, and that ridge closes on its own. So that's, I think that's a very interesting concept of not having flaps to repair the iridodialysis. Now, coming on the IOL power, I usually refrain from putting multifocals in young children. My latest favorite is putting in some EDOFs if the patient is, let's say, as Dr. Arul said, 15 years and above, yes, fine. But younger patients, I'm very happy putting a monofocal lens, because multifocal lenses in young children, the incidence of fibrosis, capsular phimosis, sometimes there are decentrations. A lot of things happens in children which are beyond your control. The way the capsule behaves, the way the IOL will vault forward or backward, you can have an optic capture. A lot of things can happen. And with a multifocal, such a complex optical system in the eye, and things going wrong can be little nasty for the young patient. So it's a good idea to put in a monofocal. And I've just done 4 or 5 patients last 1.5 to 2 months where I preferred EDOFs in patients, 16-year-old patient coming with a trauma. I'm far more happy. At the most, they'll still work on pass off as a monofocal lens and not have the trade-offs which you can have with a multifocal lens.
Yes,
Chitra madam, if I can say something, I'd beg to differ from that, because I've been doing multifocals in children for a long time. I'm a pediatric surgeon as well. So a well-done pediatric cataract surgery would have a very clear visual axis, no fibrosis, because you're making the posterior rexes as well and doing a vitrectomy also. And if you fit your multifocal or a trifocal well between the leaves of the anterior and posterior capsule, I have seen that such children are very, very less prone to amblyopia compared to children with unifocal IOLs, because the near vision is very clear, and near vision is a prime factor in getting over amblyopia. Though it will never be like the other eye, provided it's a unilateral cataract, but it does help. And in these children, binocular vision matters much more than any sort of reduction in contrast sensitivity or whatever else to be scared of at that point.
Yes, agree.
My only humble submission here is that we're dealing with a traumatic cataract, and the way a traumatic cataract will behave with post-inflammation and all that manipulation sometimes can be out of control of a surgeon. So that's the space I was coming. That's the space I was coming from.
Ma'am, can I add one point, ma'am?
Yes, Deepti.
Ma'am, I think whenever we teach our PGs, fellows, we always teach that vision in children is a complex thing. It is a combination of vision, distant vision, near vision, contrast sensitivity, stereo acuity, and vernier. There are 5-6 points which fall into it. So if you consider all the previous multifocals and somewhere if the contrast or glare is going to go down, I think with respect to that, somewhere a perfect 100% vision may not be responsible. But as compared to monofocal, if a well-done PPCR and a vitrectomy, the vision would somewhere be better than the monofocal lenses, is what I agree with ma'am also. But in a case of traumatic cataract, definitely no multifocal. I have tried 2-3 EDOF lenses as Kamal sir has put in a point, and definitely that is working a lot better as compared to that of the previously 1 or 2 done monofocal lenses. Multifocals.
Right. Good. I think, yes, Dr. Rohit, you could add your point and we shall go on to our next talk.
I think just everything has been taken care of. What I usually do when there is a lot of iridodyl, I'm talking about the surgical technique, slightly differently I do. I would have put, iris hooks to, initially, and dilated the pupil so that there's a better access and done everything, and then I would have done the repair, iridodylisis repair, by using Amar Agarwal Priya Narang technique of using a trocar at the limbus, because that gives that makes an ordinary surgeon become more dexterous, because of the advantage a trocar helps in moving the needle in from all awkward angles. So trocar, and I would have I would have done used the iris hooks initially to dilate it and then done it. So this is the way I would have done it.
Yeah, true. There are different ways, but she did so simply and nicely.
Absolutely. I'm just telling you a different way. At times, if the iridodylisis is more, you rather than first take care of the cataract and then do that.
Yes, true. I agree. Thanks a lot, Deepti. That was a very nice presentation of yours.
Thank you, ma'am. Thank you.
Yeah, we shall now go on to our next speaker, Dr. Swapna Nair, who's a senior consultant in cataract, cornea, and refractive services from Southeast Asian Center for Ophthalmic Care, Sri Netra, Trivandrum. And of course, again, a very versatile surgeon, and look forward to seeing her video. On to you.
Thank you, ma'am. I'd like Mr. Sunil to play it. I had already asked him.
Mr. Sunil?
I'm playing the chair.
There are times when early detection and careful management of a tricky situation during surgery can save unnecessary instrumentation. It all started with the dimpling of the capsule during the initiation of rhexis, when a nagging doubt crept in as to the status of the zonules. The few initial chops went okay. till the third one lifted the whole of the nucleus out, putting strain on the zonules further, not to mention the hard and leathery texture of the cataract. Inability to freely dial the nucleus also indicated trouble. Clearing of a part of the nucleus revealed anterior displacement of the inferior capsular margin and cortex, which after inflation with viscoelastic did not reveal an abnormal red reflex when checked with a Kugelin's hue. The rest of the emulsification went on fine, till it was only the last piece that was left. And lo, into the tip came the capsule and vitreous. So it was not without a reason, after all, that the mind was crying wolf. A high-density viscoelastic pushed the vitreous and capsule back. Now, in came the CTR. The trick here was to bypass the nuclear fragment and insert the CTR into the bag, which was done with care. This showed that even late placement of a CTR does not compromise the surgery in case of weak zonules. The emulsification of the rest of the nuclear fragments proceeded uneventfully. Gentle hydrodissection of the cortex from the posterior capsule aided its clearing in spite of the CTR, and the last few wedges of cortex from the dialyzed capsular zone were also removed with ease. The presence of a single strand of vitreous warranted the use of microscissors instead of the vitrector. The lens was placed in the bag with the haptic in the region of the zonular dialysis, and it was centered well. This video highlights how a CTR need not be placed early in cases of zonular dialysis, provided the maneuvering is careful.
Wonderful video, Swapna, and showed it so difficult, hard cataract, and you did show it very gracefully. But then, on hindsight, just to be critical with the video, so that some more points come out of it, if in doubt, I would have preferred to place capsular hooks to support the capsular bag, because it was a very hard cataract. And although you treated it as if it was just slicing a piece of cake, but there are challenges which come along the way. So maybe a capsular hook would be better, because you are placing your CTR much later. But I do agree that there was no evidence of zonular weakness till that exact moment. So this is just a thought for the other expert panel to give their thought. And a very important thing, I'm sure you did it, I didn't notice that, but it is also very important when we are talking of CTRs, we should ensure that the open end of the CTR is never at the area of dialysis. So you rotate it such that the long arm comes to lie in the area of weakness. So pertaining to my first question, whether would any of you have wanted to use a capsular hook, or would you consider it as an overkill? And the second thing which I wanted to also comment on is, yes, there was just hardly an evidence of vitreous, but if there has been a zonular weakness, I would still, the present understanding, I would inject tricot to see whether there was no vitreous, and then be sure there is no vitrectomy. It's not that next morning I see a peaking of the pupil. So maybe I would have done these two things. Dr. Arul, would you want to?
That's very beautifully handled, difficult situation, hard cataract with the weak zonules. But I would have put in the CTR right when she had stopped halfway and found that the inferior rexus margin was moving into the center. At that point, I would have placed the CTR and saved myself a lot of, palpitations and other issues, and maybe avoided even that little bit vitreous coming out. But it's been handled very well. And as you said, Chitra, yes, if things were getting a little hairy, it would have been better to put a capsular hooks. But as the whole thing turned out, it did not warrant a capsular hook. I would say, going back and looking at it critically, I would have placed the CTR a little earlier. That's about all. Otherwise, it's been handled very well. So this is one tip that we keep in mind. Don't hesitate to put the CTR early.
Yeah. Especially.
Yeah, I think she was able to manage it. This shows how good her tissue handling was. Yes. Because going all the way without using any aid like a CTR or capsular hook shows that she did it meticulously. My plan of action for all these patients is very simple. I do not use CTR at the start. The concept is as late as you can, but not later than good. So
you can.
As you can.
Not later than you can.
Yeah, you can, absolutely. So the first thing is capsular hooks could have been used earlier, because these capsular hooks act as, zonules. They immobilize the capsular bag. And, when she tried to rotate, this showed that the zonular laxity was there. And at that point of time also, capsular hooks could have been added. When these nuclear fragments are hard, you can use them also as a scaffold, because they also provide some support. So when you are using, when the nuclear fragments are hard, you can delay the use of CTR. But in cases where the nuclear fragments are soft, there, with capsular hooks, one can add these CTRs early on. Last piece, when she was there, she could have used, or I could have, whosoever would have been, could have used IOL as a scaffold also. You put an IOL CTR, so that also gives a support of the, of the fluttering posterior capsule. So my, pearl is that do not hesitate to use capsular hook right from the start, because they are a very good adjunct in one's practice. Iris hooks should not be used because they do not give an anterior-posterior support.
Valid. Just a brief comment, anything different, not the same points.
Yeah.
Yeah.
Yeah. Okay. I think a very well managed surgery. I would only make a few additions here for beginners who are observing the session. Aim for slightly larger rexes than you normally would have done when you're entering and trying to do a hard cataract, because maneuvering the pieces is slightly easier. I agree with Rohit. A lot of times when I have such a situation, I place the hard nucleus in the area of subluxation, which actually acts like a pushback mechanism for the capsule to come up. And I would agree. But one thing is, even when you place the lens, and if in case you're not going in for a CTR, it's a good idea to place the maximum diameter of your IOL, which means the peak of your haptic, towards the area of where the zonal loss has been there, which also acts like a scaffold and pushes the capsule back.
Yeah.
One point I hadn't mentioned in the video was that as soon as the zonular dialysis was perceived, I reduced my parameters. So for beginners, I think that should be an important point, not to go full vacuum, full irrigation and flow and all that stuff.
And you can also use viscoelastic pushing into the bag, pushing the bag backwards.
Exactly.
Sometimes you can use a methyl cellulose or a high viscoelastic also, which works like a CTR or a project. But remember, never put it into the anterior chamber. Put it into the bag. Because if you put it in the anterior chamber, it can break through the zonules, get into the vitreous phase and cellular bag. The bag will be pushed back, and you can rotate your hard nuclear fragment into that area, and they push back the subluxation or the breakup of the bag, and you can get away with it.
Wonderful video, Sapna. Truly a joy to watch your videos. Has Dr. Vaishali connected yet? Dr. Vaishali has not connected because she was our first speaker.
Yes, she's there, ma'am.
Yes, ma'am. I'm there. Yeah. No, I was actually looking for you. I don't see your name. So I'm so sorry I made you wait. I kept on wondering where you were.
I'm there.
So we have,
I was traveling, so that's why I had issues. Yeah.
We have, just a minute. We have Dr. Vaishali Une, who is a professor and head of the department of SBH Government Medical College from Dhule. And she's going to again teach us some more. Thank you, Dr. Vaishali.
Case of manual phaco-fragmentation. This is a pre-senile case, young adult female of age 40 years. As I said, this is a pre-senile cataract. We have thickened Tenon's capsule. So I'm just taking a 3 mm incision. I'm taking a scleral incision and not a clear corneal incision. A frown incision. So this is my 3 mm only arc through the scleral tunnel, making the corneal pockets, and here in the sclera I am making the scleral pockets. Though this is an immature cataract, I will prefer staining it with the blue dex. So roughly around 30 seconds are passed. Washing away the Blurex dye. Using the centripetal force, I have completed my rexus. So you can see a circular rexus margin. Watch the dimple and entry in the anterior chamber, exactly 3 mm. You will see the fluid way. I will be trying to do the manual phaco-fragmentation with the help of a visco and a Simco flow. This is the manual phaco-fragmentation. You can see it is easily getting phaco-fragmented. And this is the last piece. You can see we have removed the nucleus through a 3 mm incision with the help of a manual phaco-fragmentation. This is case of intraoperative floppy iris also, hence the iris was trying to come in the wound. The subincisional cortical matter. The unfolding of the IOL. You can see that the iris is quite floppy. Flaps of the capsule rexus. So that is the end of the surgery.
Thank you, Dr. Vaishali. A practically unedited 4-minute video you have shown us about how you would deal with it. But there are my a set of queries like if there is, if you, majority of these older patients they tend to have a more of an against the rule astigmatism. So maybe if you're making a 3 millimeter incision, why wouldn't you use a temporal approach? Because that would help also a bit. You did it superiorly. I mean,
Right.
That could be a thought. And I'm not sure about, nowadays I do know SICS surgeons are looking at smaller incisions, but fragmenting the nucleus with a Simcoe in the anterior chamber, you could maybe get away with it as it was a softer cataract. But if a harder cataract is there, what would you have done?
Ma'am, for the harder cataracts, I prefer using Dr. Anil Shah's snare. But this is done only with young patients, pre-senile, and for the traumatic cataracts in young patients, when there's nuclear, we know that the nucleus is not hard enough and it's more of a cortical matter. So these I prefer for the nuclear manual fragmentation only specific cases. I agree that it cannot be done in all the cases, and for that then I prefer the snare technique.
Okay. I think my expert panel is all got phaco surgeons, and that is my limitation too.
One
Anaga,
point.
Want to add anything? Yes, Dr. Kamal, if Anaga could
The
also.
only point I can add as a phaco surgeon to an expert SICS surgeon is when you're doing live recordings, make sure your anesthetist uses a hearing aid, because your pulse oximeter was much louder than your voice. On a lighter note.
Point well taken, sir. Yes, yes, I agree.
Anaga, do you have anything to add?
No, ma'am, lovely surgery, very nice. And there are in SICS, the advantages are that in harder cataracts and very dense brown cataracts, even for us phaco surgeons, I think all us phaco surgeons need to know it as a backup. So even though we do it almost 99.99% of the times, but there are still some times where you might have to recourse to this. So I think this is an art that all of us should know.
No, I agree. I meant the fragmenting of the nucleus.
Yes.
In a harder cataract. Would you have any thoughts on that?
No, ma'am, that was well done.
Dr. Arul or Dr. Rohit, anything to add before we?
In this kind of a situation, yes, you can get away with 3 millimeter MICS by breaking up the nucleus physically in the anterior chamber, no harm. But personally, with this kind of a floppy iris, I would have preferred to do a phaco with a tight incision so that the floppy iris is also controlled. As good results. It's very well handled. It's one technique that you can use. My preferred way would be to go for a phaco.
So, having working in a government medical college hospital and being a teacher, so primarily the surgery which we teach our residents first is SICS, and then we convert it to phaco. So most of our surgeries are done by SICS ways only, and then
you don't even have to justify, Dr. Vaishali. I think we have so many SICS surgeons in our country who can promise they're getting a minimal SICS, a minimal SIA, and a good very good controlled astigmatism, and the way they deal with all the moments with the dissection of the bisecting the nucleus and all that. So I think we truly have to respect every surgery which gets optimal results. So very nice. Thank you so much. We shall now go on to our next speaker, Dr. Kaushik Hegde, who's a consultant at senior consultant at Butts Eye Clinic and Netra Jyoti Advanced Eye Care Center from Kannur. Right? I'm right, Dr. Kaushik? Dr. Kaushik, you have to unmute yourself.
Yes, ma'am.
Yeah, and he is going to show us a pediatric traumatic cataract. I think this is the second or the third case of pediatric traumatic cataract we are seeing in our series today. On to you.
Just a minute, ma'am.
Ma'am, I just lost my connection. I hope I've.
Yeah. No. You were there right through, and we truly enjoyed watching your video. Thanks so much, Doctor.
Is my screen visible, ma'am?
No, your screen is not visible, Dr. Kaushik.
No, ma'am.
You want Mr. Sunil? Yeah, it's visible.
I started. Please.
You can start. Please start.
Good evening. Thanks to Dr. Chitra and team for the invite. I'm Dr. Kaushik Hegde, practicing in Karwar, Karnataka. My case today is a 9-year-old child who sustained a cracker injury 4 years back, complaining of blindness of vision. He has significant cataract with associated injuries, as you can see. The retina appears to be normal. My standard plan here was to use iris Fuchs and insert a 3-piece IOL. You can see the blue has gone behind into the vitreous also, suggesting a possible breach of the anterior piece of hyaloid. The repair of iridodialysis was beyond my capabilities, so I thought I will not attempt that. Firstly, during the rexus, of course, in pediatric cataracts, it has its own set of challenges, but you do a few and you'll know what to do. In this particular case, the rexus ran off. I could not complete it. So I had to do a can opener, as you can see. I didn't start well, so I couldn't complete. So ultimately, I had to do a can opener in this. The aspiration as such is straightforward. It comes out easily. Just a little bit of hydro and IA. Now towards the end of lens aspiration, I noticed that there might have been a breach there and there. So at the side port, there's a blob there, which I think would be vitreous. And did all the usual things, injected viscode and examined. Then after that, I thought I will place the lens first and then try to think about it later. So 3-piece lens in the sulcus. Now, if I know what I know today, I would have stained this at a particular stage with triamcinolone, which I did not do on that day. I did, however, prepare for peritomy, thinking I'll do anterior vitrectomy. But then after placing the lens, after sweeping the side port a few times, I thought that there was no vitreous near the wound. So I thought anterior vitrectomy was not necessary. The aim was to secure the wound and sutures and air bubble and things like that. And once the air, my way of confirming on that day was if the air bubble is has sealed the wound of the side port, then probably there's nothing there. And that was my way of confirming it. Thank you.
Thank you, Dr. Kaushik. Of course, as you said that it always makes sense to ensure that we do inject tricot and we truly sure that
I had not done that. I understood my mistake. I thought I'll show that mistake. Now, of course, over the last 2-3 years, I've been doing that. But before I didn't know, so get away with it. So,
and yeah, the end of the case, it didn't look that there was vitreous anywhere on the side boards. But what can really happen is you are surprised that these lenses could get decentered on the table. It looks all right, but then a blob of next morning or a week later, you see a blob of vitreous has come forward from that area and is actually in there in the anterior chamber. And then you are left with a lens inadequately placed, So then that becomes an even greater dilemma, and every visit of the patient, you are a little anxious about it. Any thoughts, Dr. Rohit?
I think he did it, as he said, perfectly fine. Everything was okay. And I know that repair should have been done along with. And I think this is the way, as the earlier case also, which had that aerodialysis, iris hooks were used. They were adequately used, nicely used. Then, triamcinolone should have been used, and vitrectomy, as you already told, and I would have done iridodialysis repair also along with.
Yes.
I know. Anything, Dr. Kamal, before we move on to the next?
I agree with what Dr. Rohit says, but somehow I think it's very good to discuss this about using a triamcinolone. But of all the places where I seldom use this thing, I don't know, you can strike it off the record. But I think maybe it takes time to know when you want to and you can't use it, or when you have to avoid using it. But overall, I think it was a very well managed case, using iris hooks at the right time.
Sir, sorry, sir. I have a couple of questions, sir. This triamcinolone, the dilution is 1:10. Am I right, sir?
Yes. Yeah.
Okay. And the other question is, this was a pediatric case. This just question is regarding the previous case also. If there is a PCR, the protocol is 3 Ps in the sulcus. With respect to centration, question is, I've had a few cases, very old, which I put a single piece, and they have come with repeated bouts of uveitis.
Absolutely.
A single piece in the sulcus is a strict no-no.
Yes.
I know right now. My question is, the 3-piece lenses from Alcon or AMO is acrylic material and PMMA handpiece. PMMA haptic and acrylic optic. My question is, a PMMA single piece lens, is it as inert as a 3-piece Acrysoft lens with respect to post-op recurrent uveitis? Not with respect to maybe centration, because centration obviously 3-piece will perform better, but with respect to post-op uveitis, can we put a single piece PMMA lens in the sulcus?
No.
I think we had been using it earlier in those days where, we were doing extra capsular surgery. And in those days when we were doing extra capsular surgeries, we were not clear. We were doing envelope technique or other techniques. The haptics were at times going into the sulcus also. And, they were not creating those many problems. But yes, a single piece hydrophobic or hydrophilic lens should be definitely avoided in the sulcus.
Yes.
By all means.
At the present day understanding, I think Dr. Arup is there with us. I don't know whether you watched the video.
Yeah, I watched part of it. So I think it was a good presentation. I just wanted to say that we would like to avoid a rigid lens. I mean,
absolutely.
The question was a single piece of PMMA lens. We would not like to
PMMA lens.
Would
Okay,
not but then if it is not available, it is better than putting a single piece.
Yes, it can be taken the sulcus. Only problem is you need to see the sizings. Anything that goes into the sulcus should not be less than 13 to 13.5 millimeters.
Absolutely.
13.5. But many of these lenses, many of these lenses are quite small sized, 11.5, 12 millimeter. And the optics actually, may not be equally proportionately large. So there will be chances of decentration if we have not been careful about sizing the lenses. On the other hand, the 3-piece lenses from Alcon or Johnson & Johnson, they are 13 millimeter overall length, 6 millimeter optic.
Yeah.
So I think they are preferred. They are more preferred.
Okay.
Yes.
Can I add a small point here, Dr. Chitra?
But very brief, because we have
very brief. Okay.
Of speakers still left.
See, I think the better devil between all is, in case you don't have an lens, a hydrophilic lens probably is more possible in the sulcus than a single piece square edged hydrophobic lens. I think that's one point I'd like to make in case you have no options.
Okay. So thanks, Dr. Kaushik. I'm sure we answered some of your questions.
Yes, ma'am.
You just did your bit brilliantly. Thank you so much.
Thank you.
We shall now go on to our next speaker, Dr. Chetan Kumar Ahivale, who's a Senior consultant phaco surgeon from Sri Myra Netralia from Thane. And we look forward to watching his video. On to you.
Thank
Again, a traumatic cataract here.
Yeah, good evening, all respected seniors and colleagues. At the outset, I would like to thank Chitra ma'am for this opportunity. Just allow me to share this video. So I hope everyone is able to see the video now. This was a case of pseudoexfoliation with grade 3, grade 4 cataract, and while performing the rexis, there was a minor accident in the OT where the visco syringe broke, and a small jerk happened to the cataract, and that caused the zonular dialysis at 6 o'clock. So it was noticed that more than 1/4 of the zonules were broken, and a decision was taken to convert this phaco into iris claw IOL lens implantation. So a tunnel was made and the paracentesis was created. Now here we have to take care that the paracentesis are not corneal, they are slightly on the posterior limbal side, so that we have better access when we are implanting the IOL and tucking the iris haptics into the enclavation of the haptics. So to begin with, a good anti-vitrectomy was done, and it was made sure that all the vitreous in the antechamber was cleared. Once the lens matter was cleared, the extent of the zonular dialysis was noted, and it was much more than 1 quadrant, involving almost 2 quadrants. So inserting a CTR was not an option. So the nucleus was, the tunnel was opened, and the nucleus was tumbled and removed from the tunnel. You can see that here. So the whole complex of the nucleus and the bag came out from the tunnel. It was just nudged a little bit, tumbled upon, and visco was injected around it, and it was safely delivered out of the anterior chamber. Once the nucleus was out, the cortex was removed, and the antechamber was checked for any remaining vitreous. We can use triamcinolone here to clear the vitreous. And again, a thorough anti-vitrectomy was performed. Again, a new paracentesis was made because the initial one was more corneal, and we had to make a more posterior limbal paracentesis so that the approach is better. And here we can see the vitrectomy cutter going through the tunnel with the irrigation on, and vitreous being cleared from the anterior chamber. Good anti-vitrectomy is essential for iris oil fixation. So enough time was spent on clearing the vitreous from the anterior chamber. Once we saw that the pupil was circular, it was again checked if any cortical matter was remaining. So now we can see that the intraocular structures, they are more freely floating now. So we can be sure that there is no more vitreous in the antechamber. And once it was done, we injected iris claw lens on top of it, on top of the iris first, and then oriented it correctly horizontally, which we'll see in the next part of the video. So we use iris claw forceps sometimes. Sometimes we do not have the forceps that we need, but we can use this forceps, which is a lens holding forceps, and since hook in the right hand. Many people use a 27 gauge cannula for tucking the haptics in the notch, or what we call as the enclavation of the haptics. Again, carefully, the iris was tucked on the other side, and the forceps was carefully removed out of the antechamber. So a wash was given, and finally the tunnel was sutured to make sure that the AC does not leak. So all precautions were taken correctly to place this iris fixated IOL, and the surgery went well, and the patient had good visual outcome at the end of the surgery.
Well done, surgery, no doubt, Dr. Chetan.
Thank you.
But it's just that I know I've been repeating myself on this. I would want to suture the main wound, and I would want to do vitrectomy through the 2 side ports. I wouldn't want to keep the main wound open. I think
Absolutely.
it's definitely pretty dangerous. You know, we could land in huge trouble doing that. But otherwise, you did the whole thing very confidently. The other thing is, I also believe that if you have done a good vitrectomy, you could do an iris clip IOL without a PI. But I do believe there is a controversy on that issue. Anybody, Dr. Arup, Dr. Kamal, Dr. Arup, Arul, anybody wants to add anything on this?
Yeah, here we have got 2 lessons to learn.
Yes.
This whole catastrophe is only because of the cannula just shooting out from the viscoelastic.
Absolutely.
It's something we need to remember. Even if the sister gives you this viscoelastic every day, we probably use it 3 or 4 times in every patient. Check it personally, tighten it yourself every time.
Absolutely.
Very important, because every one of us has done this mistake. I'm sure that everyone. And this is when you really have created a disaster when it should not have occurred. This is something we have to learn. 2, how to handle the situation been done beautifully by the surgeon. I would just question whether it would have been possible to put in capsular hooks, lift this whole thing up, do the phaco, and then put in a capsular segment ring and save the capsule and put a lens in the back. It's also could have been possible, but it's very difficult to make a decision looking at a video. The surgeon at the spot is the one who will make the decision. So whether that would have been possible.
Yeah.
Say a few comments actually. So it was actually a well-handled complication. But, for aesthetically speaking, don't have those air bubbles in the anterior chamber. Whenever you're doing some procedure, some manipulations intracamerally or vitrectomy, these air bubbles really come in the way. In this case, of course, it was a gross, there's no PC, but there's certain situations where, you need to be more refined in your over visualization and approach. The second point was, the cutter was moving at random, in a Brownian motion, zigzag motion. When we do the vitrectomy, we always keep the irrigation as far as possible from, where the PC rent is located or where the pupillary area without the. And then when you do the cutting, it has to be done in a more controlled manner. It is not as if you are going to aspirate the cortex from all over the place in a very unsystematic manner. And it is these sort of situations, definitely it helps you if you stay in the anterior chamber with the triamcinolone and acetonide to know where to stop.
I agree.
1 point.
Yes, Dr. Kamal, before we go on.
I think if I'm not wrong, I noticed that, your cutter at some point was going through the main wound. Yeah. That's a strict no. That's a strict no for me, at least. And I would agree with Dr. Chitra, always stitch your main wound, make a new paracentesis or a new side port and do the thing. Because doing your cutting through the main wound is asking for trouble, more viscoelastic coming out. And as Dr. Arup said, your fluid being directed into the vitreous pushes more vitreous out, and your wound is leaking, your skull loop is dipped, there's more vitreous coming out. So I would that's one thing I would do differently.
Yeah. So sir, sometimes
the PI for the iris clip, IOL. You all don't do iris clip?
No.
Oh. Dr. Arup?
SFIOL Yamane's technique.
Okay, right. Dr. Arul?
I don't do a PI for iris clip IOLs. I don't find a need for it. I'm not sure whether that's really necessary.
Yeah, I think a good vitrectomy is needed. If that is clear and out of the way, then we are left. You are safer doing a PI if you want, but that's okay. Thank you very much, Dr. Chetan. Thanks a lot. There's so much for discussion and very nice video. We go on to our next speaker, Dr. Rakesh Shah, who's again a cataract refractive. Are you a vitreoretina surgeon too?
I'm a VR surgeon doing cataract and refractive.
Oh, okay. So it's the other way around.
Yeah.
And from Swarashi Netralaya, Mumbai. And he's going to show us a case of opacified IOL. So on to you. Now, it's something we don't see very commonly enough, and I'm sure I would like to learn some more on this.
Can you share your video, or I'll share from my side, ma'am?
No, Mr. Suni?
I will share, sir.
Send 2 videos. I want you to share the opacified IOL.
So these are series of videos where there are partially or totally opacified IOL, where we have done a visco dissection for the IOL, cutting of the either optic or haptic with a special IOL cutting scissor, and then putting a 3-piece IOL in the sulcus. viscoelastic like sodium polymer. It's very easy to separate the optic, but its haptics are very firmly adherent. So in my early case, it was a tough time to remove my haptic. In later case, then I had chopped off the haptic with the IOL cutting scissor. Rather than struggling for removing the haptic, I had chopped off the haptic, just removed the optic and then put a IOL. In the case of DSEC, it's opacified IOL. Use the endoilluminator to find out the exact capsular support and then put a 3-piece IOL. So
nicely done surgery, Dr. Rakesh. That was nice.
Thank you, madam.
But I don't think we see much of opacified IOLs nowadays. But interestingly, I did read an article that opacified IOLs at time was also because of the huge temperature difference. These were stored at a very low temperature and you needed to bring them back to the room temperature before you implant these IOLs apparently, and keep not giving that due waiting time, and then you insert these IOLs. Apparently they got opacified. So
what we are seeing currently, madam, is a lot of these patients, especially post cornea surgery or where there is an injection of the C3F8 or any gas in the anterior chamber. So for a prolonged time. So rather than air, we get a localized opacification in this IOL rather than getting a totally opaque IOL. So my last case, which was a case of a patient undergone DSEC, we had a rebubbling twice and then had to put a C3F8. And then we got a central opacification almost after 2 years of surgery. That was a hydrophilic IOL. The other two were the old operated like 7 to 10 years back, they got a total opacification. But then yes, we do see such cases at least once in a year now.
Okay. Oh.
Yes, you're absolutely right. You know, we really come across these patients and there are different, patterns of opacifications. We have in PMMAs also, wherein we have snowflake opacification. In silicone oils, there used to be, discoloration in silicone oils, calcification in hydrophilic IOLs, and glistenings, in hydrophobic. So all types of IOLs have, no doubt, in a limited manner. So they are there, whether irrespective of the fact whether any vitreous surgery or oils have been added or not. But I think what you did was you beautifully managed it, and there's because they are stuck up, you try to visco separate it or use a flattened a spatula also to separate it, but still the haptics don't come out. And I would like to congratulate you the way you did it. And but we have to realize that these opacifications are common, they're in practically all types, and we do come across these patients. In Indian, scenario, the most common, no doubt, glistenings of hydrophobic, and everybody knows about it. These hydrophilic IOLs are also the primary, where we are seeing these opacifications.
Yes.
I just wanted to highlight a few points. I think, the cases have been done extremely well. So first point was, whenever, see, hydrophilic acrylic lens, there is a talk about banning these lenses in the Western market and all that, but in India, we end up using it. But I think we should only restrict ourselves to hydrophilic lenses from companies which have a long track record of, without nil opacification. So that is very important. Second thing is, any patient that may require a corneal surgery later on, a patient with poor corneal endothelial status, low Fuchs patient, hydrophilic acrylic lens should never be used, because whenever there's a bubble, even if it is for a few days, then there is, as you just already mentioned, subsurface calcification can happen. So a hydrophilic acrylic lens should never be used when a corneal surgery is considered.
Yes. Yes, Dr. Kamal.
I would agree with all the previous speakers, but I think is it a coincidence or something? In last 2 months, I've explanted 7 opacific lenses in some places. Most of these lenses, as I was agree with Dr. Rohit, again, are from unknown companies. The patient is carrying stickers whenever they've been operated in Hardwar and XYZ places. Companies I've never heard of. So the incidence of this opacification is superbly high in hydrophilics, of course. And probably I agree that, these are more in unknown companies, and this is not anything to do with the temperature. I think it's the quality of the material being used. They get calcified and they create a havoc with the patient's vision. So most of the time you cannot explant the haptic. It's stuck in the sulcus or in the bag. You need to cut the haptics and take them out. But it takes a real expert surgeon to do what is shown in the video. So I think hats off to the surgeon.
Yeah, true.
Thank you, sir.
The only thing, while manipulating, theoretically, if you were to have dialysis, then at that point of time with the haptic in the bag and the dialysis and then a CTR, would you want to place in the bag IOL, or would you decide to do an SF IOL in those cases? Now, it's so hypothetical a situation. Just your thoughts as we go on to our next speaker. Yes, Dr. Kamal.
Okay, now I would love to use a 3-piece lens in such situations. Of course, you cannot go into the sulcus because the sulcus is no longer there now. Once there's a dialysis, it's always a good idea to place the haptics 90 degrees to the previous haptics which you've cut, because you cannot possibly dial these haptics into that place. So you can sometimes suture, depending on the dialysis, create a new wound to inject the new lens, and I've done that in last 3 cases. I'll be posting that video very soon on our YouTube channel, and you can actually think out of the box, close your older wound, place a new, make a new wound to inject the new lens into the new place.
You could even do a reverse optic capture.
Absolutely.
Can do that. Okay. Good. That was what I wanted to be heard also. So thanks a lot, Dr. Rakesh. Wonderful video you showed. We go on to our next, Nilutparna Deori, who's a senior consultant at Sri Shankaradev Netralaya, Guwahati, and she's going to show her video. On to you, Dr. Nilutparna.
Thank you so much. Thank you so much, ma'am.
You have some network issues?
Yes.
You want Mr. Sunil to share his video?
Already visible, ma'am.
Yeah. Maybe anyway your video is switched off. Okay. I'm not able to hear you. Is it I have a network problem or you have? Dr. Rohit?
Yeah. Ma'am, she was supposed to do voiceover. So should I stop and wait for the connection?
No. You give the voiceover, which she gave a voiceover in her video, I think.
Yeah, she was supposed to do the voiceover. So since she is not there, we can move to the next one.
Okay. She's not there? Okay.
No,
Dr. Nilutparna, Mr. Sunil, you gave a voiceover for your video?
I haven't given a voice, so I'm going to stop video.
Because, no, if you have not given a voice here, you should change your network. We are not able to hear you.
Okay, ma'am. Okay.
So change your network.
I think we'll the next person, and maybe I can come over.
Yeah, I'll call the next person and then we look at you. We go on to Dr. Archana Chowdhury, who's a senior consultant at Arogyam Eye Clinic and Laser Center from Mumbai. And Dr. Archana is going to teach us how well to do an iris clip IF. On to you, Dr. Archana. Can you share your screen and unmute?
Yes, ma'am. So a very good evening to everyone, and thank you to the complete team of AIOS, ARC, and to Chitra ma'am for giving me this opportunity today. And there was this lady who came to me with aphakia. She was operated for cataract elsewhere about a month back, and I decided to do her other eye cataract surgery first, which was also an advanced cataract, and which went uneventful. And then we decided to do an iris claw lens implantation for this particular eye. So, an anterior vitrectomy. So before I started recording, I had already made the side port incisions by an MVR. She also had some amount of iridodialysis superiorly. So initially the first step was to do the anterior vitrectomy, which went quite okay, and there were few strands in the pupillary margin as well as in the anterior chamber. And then we entered the anterior chamber with the 2.8 cystotome. The incision was extended parallel to the wound, so to get a better wound stability. Anterior chamber then was filled with the OVD. So the iris claw lens, I like to do the patency test before I insert the lens. That is, just go parallel or swipe through the claws just to see if it is patent enough to enclave the iris. Also, holding the iris in the center makes it a better technique, so that I know, so that it is in the same line and I know where to enclave. I have a bit of, I can assume that this is the place I need to enclave. So once the IOL is in the AC and I have almost, sorry, so I have almost, I do it from the other end, the enclaving part, because I find this more easier and I get more space to maneuver rather than going from the same side. And now I will exchange the hands and insert the other haptic. But here I did make a mistake. I will get to that, but before that, I will just show how I enclaved it. And again, as I'm holding the lens in the center, I could enclave it in the same line, so I knew where to enclave it. But the mistake over here was maybe that I should have ideally gone just below, gently tapped it below, but I pushed the iris a bit more and there was some bleeding occurred on that side of the iris. We could manage this by bimanual aspiration, and the bleeding did stop, and the AC was cleared of all the clots, blood clots. And finally, I sutured the wound with a single interrupted suture with 10-0 nylon. And the wound was hydrated enough and air bubble was left behind. So to further tamponade if any bleeding would occur later on. And the patient did very well post-op. I don't have slit lamp pictures to show, but the patient did very well. She was almost 6/12 partial vision in this eye.
Yeah.
Thank you.
Thanks, Dr. Archana. Yes, there were different tips of, I normally tend to enclave it the same side port. I don't go across, but that's the way of doing it. I just felt sometimes instead of assuming aphakia, we could even place iris hooks and or use a Kuglen's hook to check whether is there enough rhexis support. Sometimes if there's a rhexis support, we don't even have to place a iris clip, we could have done a 3-piece IOL. So instead of assuming there is no capsule support, no sulcus support, that is one thought I had. And Dr. Arul, How would you avoid ovalization of pupil, which can rarely happen in an iris clip IOL?
All you need to do is first enclavate from the same side. Don't do this enclavation from the opposite side. That causes trauma. That's how the bleeding occurred. Second, to avoid ovalization, you'll have to make sure that the pupil is not too dilated. If it's very widely dilated, you may have to put in a small amount of pilocarpine, wash it out quickly so that the pupil comes down to mid dilation. Third point, enclavate at the mid periphery. Do not enclavate very close to the pupillary margin. Neither do you enclavate, pull it too much, and it will cause trauma. Mid periphery enclavation, mid dilated pupil will be the way to go, and preferably enclavate from the same side, not from the opposite side.
Yes. Would you be, how would you medicate them post-operatively? Because there is a minimal iris handling. I mean, iris clip lens hardly take, it's just like one more step in a phacoemulsification surgery. That's how it goes. But would you want to keep these patients on NSAIDs for a longer time because you've done, just like any other vitrectomy case, would you want to?
No, not really. Unless there was too much of trauma, iris trauma, I really will treat it just like any other phacoemulsification with about 3 to 4 weeks of steroids and 1 week extra of NSAIDs. That's about all. I don't think we handle this any differently unless the iris trauma has been excessive.
I believe that, I don't know whether, Dr. Arul, do you do iris clip too? If need arose?
You're asking me or Arup?
Oh, Arup.
Arup, yes.
Yeah. I do not do iris clip IOL actually.
Okay.
Either I do an ACIL or I do a scleral fixated lens for this patient.
Dr.
But
Arul.
I had one comment in this very well presented video. See, at the end of the day, there was a lot of heme in the anterior chamber, for which I think the surgeon did irrigation aspiration. So I would say that instead of using irrigation aspiration device, use a vitrector, because there is always a possibility of more vitreous coming in. So that if you're using the vitrector, that also removes whatever you wanted to remove. Plus, it ensures that the vitreous is adequately dealt with at the end of the surgery.
One other question, Dr. Arul. Now, supposing the patient, you have kept the lens in the bag for this particular surgery, and suddenly the surgery turns different and you need to place an iris clip. So how would you plan your IOL power calculation in these cases?
You'll have to reduce it by about 0.5 to 0.75 because it's coming closer to the iris. That's about all. And of course, you're going to be having the added issues of probably induced astigmatism. Be prepared for that. So we'll have to reduce the power from bag place lens by about 3/4 of a diopter.
Yeah.
So what I would suggest is, before you embark on any given surgery, always have all the powers ready, for the different locations. It should not be a last moment case. Okay, please pick up that iris claw lens, and then you don't have the adequate power. Then you undercorrect or you overcorrect. So for every patient, we always have a couple of standby lenses. AC lenses, scleral fixated lenses, and then rigid lenses. Not rigid, 3-piece lenses. So these are all kept standby, so that last minute there is no commotion in the OT.
Absolutely right.
Which eyes would I avoid an iris clip lens? I think we could say if there is not good iris support, or there's an atrophic iris, or if there's a NVI, or it's an acutely inflamed eye, like eye which has had uveitis. So I think probably maybe there may be one odd situations more, but these are situations when we won't use an iris clip lens, because I think that's being very, very commonly used amongst all of us surgeons if in a situation like this. So let's avoid those situations. We shall now go on to Dr. Sarika Setia, who is again a consultant from Indo Vision Cataract and Laser Eye Center, Maharashtra, and she's going to be showing us her video. On to you, Dr. Sarika.
Okay, so can you see my screen?
Yeah. No, we don't see your screen. We see
now?
you. Yes.
Okay. Thank you so much, Dr. Chitra ma'am, for the opportunity. Today I will be presenting. So I'll just reduce the volume of this. So this was a routine phaco case where we had not expected much to go wrong. But here you see that while cortical aspiration, I have the zonular dialysis, and we can see how this I'm actually having the bag in hand. So yes, this was a tricky situation where we had not expected that this would happen. Plus, this was a premium case where the patient was promised a multifocal trifocal lens. So in this situation, I did not want to actually go in and put in the trifocal lens. So I had a monofocal lens of the same power. So I decided to continue with the irrigation aspiration, and I did the cortical cleanup. See, every time I go and do the cleanup, I can see that the bag is not giving away, and there is no support from the superiorly. So then I decided to complete the irrigation aspiration and put in a CT. Again, when I started doing the aspiration, the capsule is still coming into the aspiration port. Then I inflate the bag with the viscoelastic and go ahead, and I decided to put in a CTR. And then, yes, we were in an OT which we were not really prepared for such a thing to happen. And even that day I had a new staff also in the OT. So there was a lot of commotion going on. And yes, I went ahead and put in the CTR, and then the monofocal PCIOL was placed in the bag. And then the CTR. Now the pupil looks circular, and I put in the lens and concluded my case.
Dr.
Everyone is
Chitra's
quiet.
screen is frozen.
The screen is frozen?
Dr. Chitra's network has issue. I think
He has some issues with the network.
So, Dr. Sarika, I mean, I think, you showed a very interesting case, and you took the correct decision of not implanting a multifocal IOL. So a few things I would like to highlight here. So number one is whenever you notice that there is a very big zonular issue, you can always go in with the dry aspiration instead of bimanual or coaxial irrigation aspiration. You can always try a dry cortex aspiration. So that may be at times more friendly to the existing zonules. That's number one. Number two, when you had a zonulopathy, iatrogenic zonular damage, you remove both the instruments, irrigating device and the aspiration device at the same time.
Yeah.
Normally, what we do is we will keep the aspiration irrigation going on, and then inject OVD, and then as soon as OVD injection starts, you come back to position 0, so that the OVD is not flushed out. The third thing that I noticed was you injected OVD at the incision. That is quite a risky proposition because, I mean, I have seen videos where there have been DM detachment. The surgeon didn't realize the whole DM was detached because, the OVD was injected under the distal membrane. So otherwise, I think your decision was correct to use a single piece, monofocal intraocular lens, and we should be pretty well.
Yeah, I think if I'm permitted to add, I think basically, one more thing can be added in our armamentarium, that while doing, because this type of zonular dehiscence happens as practically everybody once in a while. The change in approach which I have started doing is that I have started doing tangential aspiration to start with.
Absolutely, yeah.
So that, that avoids zonular stress. So tangential aspiration and increasing the vacuum once you have held it, that also, helps you to take care of, zonular stress. Otherwise, everything has been perfectly.
I think you and me are on the same frequency whenever you speak. It's like you're speaking, you're pulling words out of my head.
That is why I speak before you. I know that you're going to say what I'm.
It's so similar, you even use the same words which I want to use. One thing is, I would say that once you have a zonular break while you're doing irrigation aspiration is, do not pull your instrument out suddenly. Make sure the irrigation is on for some time and come out slowly as you come out. Number one. Number two, you would inject some viscoelastic into the bag, not into the anterior chamber, to push the zonular dehiscence back. Number three, if there's a remaining cortex in that area where there's a dehiscence, what Dr. Dohit used, I use the same word for my trainees, is do a tangential aspiration of the cortex. Don't pull it radially, because then you will be pulling more of the capsule inside. Go tangential, which means go to a tangent, take it away, so the chance of dislodgement is more. And number four, again, is once you're going to place in the lens or the CTR should be absolutely not going in, and that from that port where there's maximum subluxation. Your CTR should be going in somewhere around more than half once it's inside the bag in that area to stabilize it. And in case you don't plan to use the CTR, put the lens in, bang with the haptics at the maximum area where there are zonal dehiscence. So 5 points I would add there.
If you don't want to put a CTR, you can put a 3-piece, because
absolutely
that is a better centrifuge force.
Yeah, I have a question now. I agree about all this thing that's been told is brilliant. But my question is, why not put in a multifocal or a trifocal if the bag is stable, if
absolutely
it's centered, and there is no tilt?
Absolutely, I agree with you.
See, I would say that it depends upon the surgeon's risk appetite. Postoperatively, because cortical aspiration is never complete, capsular polishing is never complete in this kind of scenario, and if these lenses tend to get decentered, and then patient develops problem, then there could be additional issues, and you maybe ending up with the regrets. So it is basically a question of your risk tolerance. How much you could do it, no harm if the patient understands what is going to happen and what may go wrong. But I would use a monofocal lens in these cases.
Yeah, I would just like to add here, just one of those VIP syndromes. I think I have one of these YouTube videos posted online where I've done the similar thing, and the title is "Oops, I made a mistake." And the title is "Oops, galti se mistake." I was operating the younger brother of a cabinet minister, and I told him, "Oh, surgery is over, everything is fine," and I pulled more than half of the capsular bag out in a femtocataract. And I put this video on YouTube, and I put in a multifocal lens, as Dr. Arup said. You can, in case you're able to stabilize the bag. I've got away with it, and the patient is still a happy patient. But yes, you can put it with the, put in a multifocal in case you didn't dislodge the vitreous, the vase was not broken, and you stabilize the bag with the CTR.
No, I think Dr. Chitra is not fully connected. There was one. Yes, Dr. Naga. The next.
Yes. Even my connection just got disconnected.
I think there was one talk by somebody for posterior polar
Just 1 minute. Give me a moment.
I think
Dr. Chitra ma'am is there?
Yeah, Dr. Vishali was supposed to present. Dr. Vishali, are you there?
No, Dr. Nilutparna.
Dr. Vishali has already presented.
Oh, sorry, Dr. Nilutparna. Yeah, sorry.
Yes, I was supposed to present.
Yeah.
Is my network stable now? Can you all hear me?
Yeah. Should I play your video?
Yes, sir. You can play my video. I can. So good evening, everyone, and thank you for this wonderful opportunity. Today, I'm going to discuss, show you a simple case of grade 1 PPC, which can actually turn into a nightmare in the hands of the beginners. This is one of my earlier surgeries. So herein I have actually started doing, after completion of my continuous capsular axis, I move ahead with doing a lamellar dissection of the cortical area, but I don't do a direct dissection. That is, it's only a hydrodelineation, which is done 360 degrees. So I create a trench which goes to the depth of only the epinuclear plate. I don't go beyond that. And once I have created a crack up to the epinuclear plate, I take off one half of the soft nucleus, and after that, I take the liberty of doing a viscodissection of the other half, which enables me to rotate the nucleus and bring out the soft cortical matter and the nucleus. So now, having completed this surgery uneventfully, I get a little excited while doing the cortical aspiration. And while doing that, I see that there is a small Mittendorf dot at the posterior capsule in the central area. So while trying to polish the posterior capsule, I actually end up doing a PC rent in the posterior capsular area because I forget at that point of time that this is the weakest point of the posterior capsule. So having created a very large linear posterior capsular axis, I actually struggle to make the posterior capsular axis with the microcapsular forceps. What I'm aiming right now is to make an ovalization of the posterior capsular rent so that I can implant my IOL in the bag. As there is no vitreous disturbance in this case, I have not injected tricort or triamcinolone in this particular situation. And after putting in the OVD viscoelastic, I have moved ahead with implanting the IOL directly into the bag. But before implanting the IOL in the bag, I have actually enlarged my main incision so that I have an ease of putting in my injector. Now, once the IOL, the leading haptic is in the bag, I gently just tug in the trailing haptic, and while doing so, you can notice that the Lester's instrument has touched the posterior capsule, and I immediately retract my instrument and I place the haptic slightly and very smoothly in the bag. So I have finally completed the surgery, but what I have learned from this is that even if it is a grade 1 PPC, we sometimes tend to forget that the Mittendorf dot at the posterior capsule, which is the weakest point, tends to give away, creating a PC rent, which can actually be very drastic for us and lead us to a lot of problems thereof. So with that, I end my video and it is open for discussion.
Yeah, thank you, Varna. That was a nice presentation, and really these take-home points and PPC cataracts are something which you have to be alert at each and every step, very well presented. Dr. Arulmozhi Vernon sir, your thoughts on this and whether you could have used a 3-piece lens in this case instead of a single piece?
No, in this kind of situation, it's the critical issues, the ability of the surgeon to convert such a large, split in the capsule into a circular posterior capsular axis. So I have to applaud the surgeon. That's been done beautifully. Once you've done that, it hardly matters whether you're going to put in a single piece lens or a 3-piece lens. If I was not very sure about my posterior capsule integrity, or if the posterior capsular axis was extremely large, larger than this, then I would have probably put in a 3-piece lens and the sulcus and reverse optic captured into the bag. That's what I would have done. So it all matters as to how adept you are of converting a vertical split into a round or an oval capsular axis. It all counts there.
Absolutely. Dr. Rohit sir, any thoughts on this?
I think she has perfectly managed it. There's no second thought about it. Plaques, you have to be very careful, whether you should be removing them or not. If there are certain conditions where you can, where you should, and those should include if you are sure that you can, if it extends, if there's an opening in the posterior capsule, whether you'll be able to complete a posterior capsular axis or not. If you are using, if the capsular axis size is small enough, wherein if the capsule gives away, and if you have to put a lens, and if you're not able to put it, if the capsule rexus is small, whether you can do an optic capture. So that is one condition where you can attempt to remove the plaque. If the patient is such that he requires a premium intraocular lens, and you can go with the idea of doing a YAG laser capsulotomy later on, then you may not remove the plaque. So there are different conditions. And if the patient happens to be a child, a small child, where you may not be able to do a YAG laser capsulotomy, in those, if you can remove the plaque and do a posterior capsular rexus, these are certain points which you have to bear in mind when you have to decide whether you should be removing these plaques in posterior polar cataracts or not.
Thank you, sir.
Dr. Arup, would you like to add something?
I think
Arup,
Dr. Chitra is offline. I think Dr. Chitra is offline.
Yes.
I think we've lost signal from her.
Dr. Kamal, would you like to add something?
Yeah.
No, I think
Dr.
enough.
Arup, sir, is
We've
there?
discussed it beautifully, Rohit. Most of the time when you're
Oh.
speaking, I'm actually thinking you're echoing what I'm speaking.
Okay.
Nikhil's case, which you are watching now, I'm sorry.
The next speaker. Yes, ma'am. She just finished her presentation.
I think, Dr. Chitra, on a lighter note, this is again a case where the host becomes the ghost.
Okay, no. We have to be relevant. This was Nirutparna's case, right?
Yes, ma'am. She just finished the presentation and discussion, ma'am.
Discussion is over. So, so then if that has been complete, we go on to our next speaker, Dr. Nikhil Kandurkar, who is from Netra Seva Hospital, Nagpur. And he is going to show us how he managed small pupil in his series of cases. On to you, Dr. Nikhil.
Good evening, everyone.
Yes, Dr. Nikhil. I think this is the first time this kind of mess happened for me.
I think this shows you're also
Dr. Nikhil, yeah.
You are such a big perfectionist.
No.
You join the ranks of the mere mortals like us, Dr. Chitra.
No, actually, I'm going to lose my sleep over this now. Leave it. Yes, on Nikhil.
Dr. Nikhil, I'm sharing. You can do the voice.
No,
start
please, let me share.
No, he shared it. You present, no?
Okay. So thank you, Team ARC.
Increase your volume.
Small case series with challenges in small pupil with hard cataracts. So we all know we have undergone such situations, and we have faced this on many occasions where while performing blind rexis, the rexis has gone away to the equator and then don't know how to do. And many a times we have caught pupil in the Veco probe because of the small pupil situation. But with practice, all of us come with some ideas to tackle with these cases, and sometimes there are situations where we manage without pupil expanding devices. So in the case, this while performing rexis, what I feel is we have to look at the fold configuration, and you like re-grasp, frequent grasp technique. You just do a small bites and then go centripetally. Is another case where there was head nodding with small medium pupil and hard cataract. I try to stabilize with the forceps in the left hand in such cases. And you just go beyond, little beyond the pupillary margin and then just follow. Such PXF cases are routine with everyone, and these are definitely challenging with weak zonules. So make sure that the zonules are not weak. And while doing rexis, you can get the idea of this. And getting just little beyond and looking at the fold, we try to just gauge the size. Sometimes you end up with smaller pupils. There are cases with pupillary membrane where you, especially post-uveitic cataracts, where definitely it's good to first clear up the membrane, take it off, following which there is a certain dilatation which can be achieved. then strain and again remove the membrane completely. Itself, it can dilate pupil to some extent, and sometimes you can use capsulorhexis forceps to go, but it's all again, it is at our own convenience which technique suit you, whether a cystitome or a capsulorhexis forceps. So most of the cases I prefer cystitome, certain cases definitely. So here managed to complete the rhexis, although it was insanely small pupil with a membrane. Most important is hydrodissection, where a complete and very good cortical cleaving hydrodissection, where pupil, where the nucleus rotates very easily, even with the air hydrocannulas. The most important technique is nucleus splitting. So rather than chopping, you have to just split off the nucleus in cases of small pupil, so that you are actually dividing it completely. So vertical chop technique, there's making horizontal blind chop again can damage the capsule. So you have to just go deep it, bury, and then you split the nucleus into 2 halves and then proceed further. While picking up pieces, make sure that you are in a proper plane and you are not pulling the iris in the Vicoprobe. So with some practice, I feel everyone can do this. Hard and cheesy cataracts, instead of dialer, you can use chopper, vertical choppers. And if it is not getting fully chopped, again, rotate it, starting from another plane. And the most important point is go deep enough, because the lens thickness is more, in most of these hard cataracts is more than 4 millimeter. So at least go midway or beyond midway, where your TP is buried up to the sleeve, and then you get a good hold and then split it into 2. Even in smaller pupil cases, there is a cover of nucleus above it. It won't cause pupillary or iris trauma. And in some cases, I prefer bevel down during the first chops to split it perfectly. So these are some take-home points. And even after that, if there is a need, I don't hesitate to put BX ring, even in small pupil cases, and it is always at ready as a backup. If I'm not able to do, I use a BX ring and other pupil expanding devices. Thank you.
Wonderful surgeries, absolute confidence in your surgical skill. Can you stop sharing? It was a wonderful control of the parameters or the technique and the ability to manage a small pupil in varied situations. And also very important that how you remove the pupillary membrane. In that kind of a case scenario, the pupil actually dilates a bit after you've done your removal of the membrane. But then somehow I'm all for using iris hooks, and I would want to know my rhexis is definitely round. So in these challenging situations, I'm all for iris hooks, unless it's a little bigger than some of your pupil and it's a soft cataract. When I know I can do it, but then again, I would ensure that I keep my phaco probe right in the center of the pupil and get the pieces towards the center. Dr. Rohit, your thoughts on it?
I think I would like to congratulate him for
amazing
excellent surgeries. You know, we are always challenging ourselves, and you know, when I was seeing his surgery, I was really you know, appreciating how well he is managing. He has planned for everything. So you know, there are a few things, if I'm permitted, I would like to you know, add on. You know, in some situations where there is pseudo exfoliation, one should try to use dilating aids. You know, this is one condition where one should definitely use a dilating aid. Parameters have to be on the lower side, as you have already said. But then, if by any means one feels that the cataract is hard, and if you want to use higher parameters, then there's a very small trick that you keep the phaco probe in the proximal half. You will not emulsify the, you know, the iris. While doing irrigation aspiration, bimanual is the preferred technique. But if you have to use coaxial one, then you can retract the sleeve more so that you have different plane of irrigation and aspiration. And one more point is that while doing hydrodissection, a lifting of the nucleus, you may not be able to see the wave, but lifting of the nucleus indicates that the hydrodissection is done. So I think he missed it out because there was paucity of time. And I'm sure had he been given more time, he would have showed all the points which I've added.
Yes, yes. Wonderful. Yes, Dr. Kamal, how could we not take your answers?
Okay, I think a beautiful surgery, perfect, I couldn't find a fault with it. But as Rohit said again, sounds like a cliche. I think it's a good idea to use a pupil expander because in pseudo exfoliation, if you make a small rhexis, the chances of having a capsule or phimosis are very high.
Yes.
Just 2 days ago, I explanted a complete IOL with the bag in a patient operated 7 years ago. Small pupil, I made a small rhexis. At that point, not probably wise enough. Phimosis, complete zonular loss. The IOL was half hanging along with the bag in it. So the tip here is maybe you can use your micro scissors, make 3 sphincterotomies to start with, use a pupil expander, iris hooks. But of course, you can do the surgery on the moment in the table. But if you actually stretch the timeline and you're looking at maybe 7, 10 years down the line, maybe, getting away by doing a surgery with a small rhexis and a pseudo exfoliation, maybe not a good idea when I look back. You should have a larger rhexis in these patients if you can help it. That's my small point.
Wonderful. Dr. Arul, I'll make you take questions in the next case. We move on. We have just 2 more videos to show. We go on to Dr. Pratik Tiwari, who's a cataract, cornea, and refractive consultant from Center for Sight Indore. Dr. Pratik, are you there? Yes. Can you
I'm here.
aid by Mr. Sunil?
Yeah.
This is a cataract case with grade 1 to 2 nuclear sclerosis. I'm sitting temporally. The patient is under topical anesthesia. Smearing the cornea with viscoelastic as it enhances the visualization. Retroillumination also helps you to enhance the patient comfort. I made 2.2 mm clear corneal incision. I always try to nick the conjunctiva near the clear corneal incision as it prevents the ballooning of the conjunctiva and chemosis thereafter. So at this point of time, I want to freeze this video and look back at this moment when it happened. As you can see, the iris has started coming out from the main wound. There is some release of iris pigments as well. I could sense some kind of increased anterior chamber pressure. Retrospectively, if I were to point out a reason, maybe the patient was doing some kind of Valsalva maneuver, or maybe the iris is floppy over there. However, there was no history of BPH or tamsulosin intake, but patient was hypertensive but was non-diabetic. And there was no iris trauma noticed in the pre-op evaluation. So I filled the anterior chamber with viscoelastic, tried to rotate the nucleus. The rotation went well. Started with stopping chop technique. I could initiate the first crack well. I got 2 distinct heminuclei. Again rotated the nucleus. Here you can make out that the iris has started tenting towards the left side port. It is getting prolapsed towards the left side port. And you can also make out that the patient is doing lid squeezing. Again, I asked the patient that, are you okay? And patient always replied that I am absolutely okay. You go ahead with the surgery. So I could sense that the lid squeezing is happening, and maybe the patient was under fear or anxiety or hesitation to express himself clearly. So I continued with the surgery. I took the last piece in the epinucleus mode. Again, you can see that the iris has come out from the main wound. So at this point of time, I was pretty nervous. So in that nervousness, I took my irrigation aspiration cannula and tried to reposit the iris. But that was not a good move because it increased the anterior chamber pressure and the iris again came out. So I took my phaco rod and reposited the iris back. This time the iris went inside easily. So after clearing the cortical matter, I filled the bag with viscoelastic. Again, you can make out squeezing, pulsating lid movements. I thought maybe the iris is again going to prolapse out, but this thing didn't happen. I was able to place the IOL well inside the bag. However, the pupil has become D-shaped. So while clearing viscoelastic, I thought maybe if the iris again prolapses out, I'll inject pilocarpine and constrict the pupil. I also thought maybe I'll put sutures on the main wound and close the incision. However, you can see there is no tendency of the iris getting prolapsed at this time. So maybe the construction of the wound was okay. So after sealing the side ports, I was able to close the case and there was no iris prolapse.
Thank you very much, Dr.
So on
Pradeep.
post-op day 1, the vision was good. It was 6/6 partial, but there was loss of pupillary frill as you can make out in the picture. Thank you.
That was again a wonderful presentation, Dr. Pradeep. Basically,
Thank you, ma'am.
think my guess is it is a mild case of a floppy iris with the iris prolapse which is happening. And the other thing which is important in your thing is besides managing the situation well, you kept repositing the iris going by through the side port, and that is an important message. If you reposit from the main port, you make it floppy. But one other tip is whenever you get the phaco probe out of the eye, it is always better to bring it to foot position 0, because if you come with the fluid at these kind of cases, the iris also tends to come out, and that makes it even more floppy. And I quite like the idea of doing that conjunctival dissection, but then again, I mean, in the case of chemosis, in a routine case, why would I try to tamper with the conjunctiva? But if there is chemosis, yes, that is also one trick. So we have Dr. Kamal Kapoor with us, continuing to stay in spite of the gun on his head. So let's take his thoughts and then Dr. Rohit's thoughts too. And
okay, you know what? Something interesting. You mentioned my wife. Whenever I talk about a floppy iris, I tell my trainees, a floppy iris is like an angry wife. You make a mistake, she'll never forgive you in that area. She'll always bring it up. So once a floppy iris starts coming from a wound, it's going to keep coming out from there. So as you mentioned properly, the right place to reposition the iris is from the side port, not the main wound. Number 2 is the next time when you're entering with an irrigating instrument, which could be an irrigation aspiration or your phaco piece, through an area of floppy iris, it's a good idea to instill a small amount of viscoelastic just in the wound to push the iris down, enter it. Number 1. Number 2, and when you're coming out with the instrument, wait, count till 5, take your foot off, depress your side port, let the fluid come out from the side port, make the chamber hypotonic. I'm repeating again, make the chamber hypotonic and then withdraw your irrigating instrument. And you do these 2-3 simple steps, it's going to work again.
Yes. Dr. Yes, Dr. Rohit.
I think while going in, it has to be irrigation off. That is another important. I feel, the patient didn't have any history of any, intake of any tamsulosin or anything. I think the tunnel was slightly shorter.
Absolutely. Yeah, true.
That was basically the cause. And whenever you have a short tunnel, you have to go with a mindset that you should not be over-inflating the chamber. When he did hydrodissection, it usually happens if the tunnel is short, the iris will come out. So he, decompressed it from side and then it became normal. And, his side port was also, on the left-hand side, well, the iris was trying to come out because that also, the side port was slightly wider than what it should have been. When he was doing IA, the iris was not coming out. So that meant that it was not a floppy iris, basically. It was basically because of the short tunnel and the sequelae created because of that. Irrigation off while coming out, definitely that should have been done. Yeah.
Yes. Very good.
Thank you.
Very good. We go on to our last presenter, Dr. Sushmita Shah, who's a consultant cornea and refractive surgery from Mumbai. And she has again a very interesting case to show. On to you, Dr. Sushmita.
Thank you, Chitra ma'am.
Actually, you had 2 videos. I'm not clear which one you're going to show now.
Thank you so much for the invite, ma'am. And I'm going to talk on cataract surgery in Fuchs endothelial corneal dystrophy. So I'll start with this lady, 52-year-old with decreased vision in both eyes. The right eye, it was best corrected 6/18/18, and the left eye was 6/12. Yes.
You need to present your screen. Your screen is not presented. Just open your presentation, come back to the Zoom window and click on the share screen.
Okay, the presentation is open. I'm not able to come to
On the Zoom window where you see the videos, there is a green button on the bottom, 6 o'clock. Just click on the button. On the pop-up, just click the blue button.
Where is it, sir? I can't see that.
Mrs. Sunil, can you share a video?
No, ma'am, I have a couple of slides, ma'am. I want to. Okay,
No,
yeah, I got it.
Not this video, not this video. The other one.
I have this video, ma'am.
No, I have a couple of. Yeah, is it coming now?
No.
Share. I have done the share.
No, you click twice. Once you do the share, the pop-up comes. Then there is a blue button. Just click on it.
Yeah. There is share and there is link to this slide. I'll do share, right?
Yes, the blue share.
The blue share. Link to this slide.
Ma'am, just click on the green button first.
Sorry, Dr. Rohit and Kamal. She'll be done.
I'm really sorry, extremely sorry.
Not at all, please.
That's why you should share your videos.
For such a long time.
Dr. Sushmita, are you on the Zoom window?
Yes, I am in the Zoom window. Yeah, this is. I can see your thing. Green.
No, yeah, the green green button. Click on it once.
Thank you so much. I think I got it here.
Perfect.
Perfect.
Oh, I got it. We got it.
Extremely sorry for the this thing. So I'll go straight to my topic is cataract surgery in Fuchs endothelial corneal dystrophy. So this was a lady with both eyes cataract and diffuse guttet. The cataract as well as the guttet was more in the right eye as compared to the left eye. So we diagnosed it as a FECD with cataract. So this brings us to the question is whether to do a cataract surgery alone or a combined cataract surgery with an endothelial keratoplasty. Now coming to the grading of the FECD, which was initially being discussed, was the Grashma classification, which grades it from grade 1 to grade 6. The grade 5 and 6 are the more significant disease, in which grade 5, it is more than 5 millimeter of confluent guttet, but usually they may not have obvious edema on slit lamp examination, but they can have subclinical edema. The grade 6 is obvious, the obvious guttet with obvious corneal edema as evident on slit lamp biomicroscopy. Now, the essential diagnostic tools include specular microscopy, which gives us not only the corneal thickness, but also the endothelial cell count. If the corneal edema is too much and you cannot get an endothelial cell count, you can use the confocal microscope. However, it is very expensive and not very easily available. The other important parameter is the pachymetry or the central corneal thickness. You could get it from the Scheimpflug topography, from the ultrasonic pachymeter, or even from the specular microscope. Now here the corneal thickness increases due to the endothelial dysfunction. One important point to remember here is that in Fuchs dystrophy, the central corneal thickness is increased because the endothelial dysfunction starts centrally, where in other endotheliopathies like inflammatory or because of HSV endothelitis, etc., the endothelial dysfunction could be diffuse or localized anywhere. Now, this is a recent classification of or description of the Fuchs based on the Scheimpflug tomography, which has been proposed by the Mayo Clinic. Now, they have outlined 3 basic features to understand the presence of subclinical edema. These include displacement of the thinnest point of the cornea, loss of parallel and circular or oval isopax, as well as the focal area of posterior surface depression. That is, because of the edema, the posterior corneal surface actually bulges into the anterior chamber. So these 3 are very parameters are very useful in monitoring eyes which have subclinical edema. And based on this 3 characteristics, the Fuchs has been again classified into 4 grades. The first one being the Fuchs with obvious clinical edema, where you can just do slit lamp examination and nothing else is required because edema is already there and you can see it on the slit lamp. The second is the Fuchs with subclinical edema, where you have guttet and you do the Scheimpflug topography. At least 2 of the 3 features should be present to characterize it as subclinical edema. Fuchs without edema is only guttet and no edema, no features on the Scheimpflug topography. And the 4th is the no Fuchs. Now, this was our patient. So you can see mild displacement of the thinnest point of the cornea and also loss of the parallel and circular isopax in the tomography. And these are her clinical photograph and the specular microscopy. The right eye, you can see very poor endothelial morphology, but the pachymetry was 525. The left eye was slightly better. So the Mayo Clinic classification doesn't tell you when to do a combined or versus when to do a cataract surgery alone. This is a recent paper by Moshifar, which which gives a guideline depending on the corneal thickness. If the thickness is more than 640, it's preferable to possibly do both combined procedure. If it is less than 640 microns, and if the endothelial cell density is less than 500, then definitely do a combined. If it is somewhere in between, then you can do also a plain cataract surgery. But if the endothelial cell count is more than 1,000, then you could safely do cataract surgery alone. So our patient was kind of in this bracket, so we decided to do the cataract surgery alone. Here is the video. That's the NS3 and some amount of corneal edema. So the dots on the endothelium on retroillumination, these again signify Gate if you've missed it on slit lump examination. Now I've already caused a small descemet membrane detachment at the entry of the needle. I still go in and do the rexis there, but good sense prevails and I create a new side port to prevent further problems. The anterior capsule, I always prefer to remove it. Sometimes we confuse it with the descemet. Now, double viscoelastic, the soft cell technique. This is the dispersive viscoelastic first, and then this is the cohesive viscoelastic under the dispersive viscoelastic. Normal trenching. Now my trench is off. I am like 2/3, 1/3. I continued this way. So the split I get is not 2 equal halves, but kind of a 2/3, 1/3 split. We should take care we don't do such mistakes. Now again, repeated injection of the viscoelastic. Now because we have 2/3, 1/3, it's preferable to remove the 1/3, the smaller half first to create space within the bag. As much as possible, keep the phaco tip away from the endothelium. Divide the nucleus into smaller fragments. The bigger fragments may come out and hit the endothelium. Again, not advisable. As much as possible in the bag, phacoemulsification. And try and split the nucleus into multiple smaller halves and remove them. Now this fragment is floating around in the anterior chamber. So this is again not required. Avoid nuclear fragments hitting endothelium. The final parts, and then again repeated injection of both the viscoelastic to protect the endothelium. We remove the epinucleus, followed by a careful IA. Again, this is the dispersive viscoelastic. And we've put the cohesive also under it, and the IOL. Here again, as our panelists were discussing sometime earlier, endothelial disease, so always go for a hydrophobic acrylic IOL. Again, make sure it doesn't touch the endothelium, do a very careful insertion. Viscoelastic washing, not only in the center, but also from the angle. This is her about 3 days later, 6/9 N6. So careful clinical examination to look for Gate, specular microscopy, pachymetry. Increased risk of corneal edema needs to be explained to the patient. Soft shell technique absolutely mandatory. In the back, phacoemulsification. Keep the nucleus away from the endothelium and use sharp instruments to avoid damage to the endothelium, and hydrophobic acrylic IOL. Thank you so much.
Yes, wonderful. Top class presentation.
Thank you, ma'am.
You covered it all, told us everything, and very well detailed. Very happy to hear that.
Thank you.
Now, just one question I have. If there is a combined surgery to be done, how would you plan your IOL power calculation? Because there's going to be a change in the posterior corneal curvature, no? Following a descent.
Yes. So
a little hyperopic.
Yeah, there's always a hyperopic shift because the posterior curvature is kind of bent into the anterior chamber. So most of the IOL power calculation formulas give you a hyperopic shift of about 1.5 to 2. The Haig's formula is considered the best because the minimum hyperopic shift is there. So preferable to use the Haig's formula and aim somewhere about 0.5 to 1 millimeter of over.
IOP.
Oh, yeah.
Oh, that's wonderful. Anything to ask Dr. Rohit? I think it was a thorough presentation which she gave. Dr. Arul, it's nice to have you there too. I would want your thoughts. She's the last presenter.
Yeah, I like to know in this kind of situation, what she's done is superb.
Yes.
She used the soft shell technique, used
Yes.
a very slow phacoemulsification,
Yes.
low flow, and not disturb the endothelium. What is your take on using either BSS or BSS plus, the one with glutathione in these kind of cases? Would it be a better option?
Yes, yes, of course, BSS plus would be advisable. We use that BSS plus here. And another thing I think I forgot to mention was the use of Rho kinase inhibitors, the Ripasudil, which we gave post-operatively for about 2 weeks. I think it helps in reducing the endothelial stress, and it helps post-operative already. She did not have any edema, at least initial post-op also, but we still gave it for about 2 weeks.
Yes.
Wonderful, wonderful.
Wonderful. Dr. Rohit and Dr. Kamal, one comment from each of you.
I think she has ticked all boxes.
Yes, all boxes.
Yeah, one thing here, I feel that in such compromised, situations where the endothelium should not be disturbed, the IOP, low IOP phaco is a relative contraindication. Because with low IOP, your bag is not that much inflated anterior segment. So you should not go into 20, 22, 24, 26 IOP. It should be around 40s or so. In my practice, I usually do for harder cataracts or where I do not need any endothelial damage. I do not go in for physiological IOP emulsification.
Right. That's a very valid point. Yes.
I'll remember
And Dr. Kamal? You should
we can't hear you.
Unmute yourself.
In these cases, again, I would probably have a little loose side ports because the Descemet's detachment in these patients are pretty common and they can be devastating. So most of the Descemet's detachment would probably start from the side port because you're using bimanual aspirators and doing irrigation aspiration. So it's a good idea to have least amount of distortion of the wound in these, because if the wound is tight, you can have a DMD while entering or doing manipulations. So I keep my wound slightly wider. Another thing with my practice I've seen is, for some reason, I use slightly chilled BSS plus in these patients. And somehow I've realized over time, it's a gut feel. Maybe it's my own thing. Maybe people can try that. I use slightly refrigerated BSS in these patients, and I have very, very minimal corneal edema. I've compared one eye to another eye in the same patients. And somehow over time, I'm just sharing a leaf out of my book. I use slightly cold BSS plus in these patients, and I seem to have good results.
Yes, all very, very valid points. And I think I have had wonderful expert panel in this. Like, I need to just ask question. I was just getting all the right answers, and I'm just, as I learned along the way, I'm sure our delegates have learned a lot too. So first and foremost, thank you so much, expert panel. Thank you, Dr. Kamal Kapoor. Thank you, Dr. Rohit Prakash. Thank you, Dr. Arul Bhuivarman, and thanks to Dr. Arup Chakravarti for the short duration he was there. Apparently his father is not doing well. So for the duration of period he was there, he gave us his input. Thank you so much, all of you. Each of your talks was so diverse and different. Yes, we did have traumatic cataracts, but we brought up different points to discuss it and different aspects were handled. And I think just as we learned, I'm sure each of you also learned, and it was a nice meeting. And of course, I need to thank Mr. Sunil for being such a fantastic right hand that I could possibly have. Only thing, I wasn't too lucky and my network failed for a short while, but I had my sweet Anagha there. And of course, my expert panel also carrying on the discussion without me. And that was so nice. And I should thank Mr. Kripal and the admin team of AIOS for their support. Thanks to Sai and Manjula from Numerotech for their constant support. And of course, I have to thank Entod for sponsoring every single webinar of mine so graciously and so helpfully, and I'm so indebted to them. And thank you so much, delegates. You know, when I meet some of you all at the different meetings and the kind of encouraging reports which you all give me, that how much you all enjoy it, and you know, the messages which I receive from different corners, it makes me so happy But I know I have just touched the tip of the iceberg. There are so many of you there who I have not reached out to, but thank you so much. I have learned a lot by trying to help you all out. Thank you so much.
One final shout for Dr. Chitra, who's an amazing host. She's like a professional anchor. I think she beats Palki Sharma of the Gravitas of Vion. She knows her subject truly, and the way she mentors the whole the junior people, the way she ties the dot, links the dots and makes the thing go so smooth and effortlessly. Amazing. I couldn't have even imagined doing such a great job like you, Dr. Chitra. Thanks again.
Thank you, Chitra. Wonderful.
No, but I had a wonderful expert panel. You just guys wait on. I'm going to be calling you all more often. I mean, it's superb. You all are a store of information, all three of you. Thank you so